Good morning. Sorry, we are about 5 minutes late. And this is the fifth edition of SETS program, that is Surgical Education and Training Session conducted by the College of Surgeons of Sri Lanka. And thank you to have come and some more members to come. And one speaker has to come as well. He's stuck in the traffic at the moment. And I'm Dr. Nias, President of the College of Surgeons of Sri Lanka. And though it's a fifth edition, this is the first time that I am joining personally with you all. Unfortunately, I have been very busy with other work. And let me thank, first of all, Dr. Ranga Vikramararachi, who is our college council member who is coordinating SETS program lately. The history goes back to 2004, as far as I know. It is Professor Aloka Patirana who started this continuous medical education for doctors and trainees. And that was way back in 2004. And since then, this program has been continuously happening, and it has been a very fruitful, very useful CME program. And a lot of doctors have participated, a lot of consultants have committed to this, and each topic had been selected very selectively and discussed only on that subject with the available expert, not only from Sri Lanka, and our own Sri Lankans who are surgeons working abroad also joining us. And today we have Dr. Saman Iddagoda joining us from abroad. And so it's a sort of a international program that has been, and fantastic thing. I also used to listen to this on and off. And we did urolithiasis in January, in February, neurotrauma. Third one was in March, soft tissue management in trauma. Fourth one was venous lymphatic disease. And fifth one today is cardiothoracic surgery, and both cardiac and the thoracic surgical topic. One humble request from you all. We know that you all don't know. That much we know. Or we know that you know a little bit. That's why you have joined us. So it's your duty to ask questions. We Sri Lankans are a little poor in asking questions. That is because we think, oh, my neighbor who is seated out other side, or my girlfriend who is at home, or my boyfriend somewhere might feel, oh, I'm so foolish. Please get rid of that. Don't ask the PhD questions from our resource persons. Ask a foolish question. Ask what is need to be clarified by you, because you are here, your time, resource person's time matters. So here we have come here to learn. All those people who are joining online from Kandy, Peradeniya, Jaffna, Anuradhapura, Karapitiya, Batikalo, may I request every one of you to ask questions. Yesterday we had council meeting, Rasanayaka, and we had a lovely chat, because the last program, venous lymphatic disease, had been a very interactive. The resource persons were extremely happy. That was very interactive. And so they were able to clarify. So the purpose of this program, surgical education and training session for trainees, for doctors who are interested in surgery and to be practicing surgery in Sri Lanka and abroad, please ask questions, clarify each and every topic that you want to know. And the subject, the problems that you have faced, please ask that questions. And the blunt chest trauma, management of airways, principles in management of cardiac trauma, lovely topic. Please make use of it. With that note, and may I bless you all that you have a good time and learn as much as you could. That is the way that we can go forward. Thank you indeed. Thank you very much. And may I call upon Dr. Rasanayaka to give a small introduction and invite, conduct the course, please. Thank you.
Good morning to everyone, and thank you very much, sir, for your introduction. And I want to add something on that is that not only that it is continuous medical education. In addition to that, this kind of cardiothoracic and thoracic fields are new to you guys that you don't know what are the things inside. That also just open doors for your futures as well, that you can select this kind of field, that you can have some kind of knowledge about our field. So to begin with, I invite Dr. Samanid Good, my colleague, to give a talk on blunt chest trauma. He will join online with us today.
Good morning to all of you who came for this SETS program in cardiothoracic surgery. And today we are going to discuss uh, about cardiothoracic trauma in general. And I'm going to discuss about management of blunt thoracic trauma, one of the common presentations that you will see in Sri Lankan setup when you are practicing as general surgical registrars during your senior registrar period. And again, if you happen to work in a periphery, you have to manage these patients, especially if you are working as a general surgeon. And thoracic trauma is one of the commonest presentations in an A&E in Sri Lankan setup, as well as in other countries developing, as well as in Western countries. And most of these patients are managed by the A&E teams and primary teams who has been involved in the management of acute and emergency patients. And after the initial management and resuscitation, these patients are referred to the specialized teams, cardiac teams and thoracic team for further management. And in local setup in Sri Lanka, non-accidental violence is the commonest form of penetrative chest injury, and you see a lot of news in the media regarding gunshot injuries and stab injuries. And as said, yes, that is the commonest presentation nowadays. And motor vehicle collision is the commonest form of blunt thoracic trauma in Sri Lankan setup. And the mechanism of injury in blunt thoracic trauma is mainly because of the impact and then energy transfer. There will be a sudden acceleration and deceleration forces acting on the viscera of the chest, internal organs, which will resulting in damage to the internal structures. So common injury patterns, the chest wall injury is the commonest, followed with hemothorax and pneumothorax and pulmonary injury. And the less common ones are diaphragmatic rupture, esophageal rupture, and very less common is cardiac injury and then aortic injuries. In Sri Lankan setup, the data we collected in 5 teaching hospitals, major trauma centers in the country during the period of 2017 and 2018. And out of the patients, 171 patients, the majority, as expected, are the male patients, and automobile accidents were the commonest form of mechanism that these patients had injuries. And more than majority of the patients had extrathoracic injuries. And as mentioned here, lower respiratory tract infections, bronchopleural fistulas, and tracheobronchial fistulas are the related complications following these thoracic injuries in that cohort. So in this graph, you can clearly see the rib ruptures, hemothorax, pneumothorax, and lung injuries are the common presentations that we saw in Sri Lankan setup. And the blunt thoracic trauma are much more commoner in A&E setup. And last year in the National Trauma Conference, we presented the data we collected in National Hospital of Sri Lanka during the period in 2022-2023, and with regard to the emergency or urgent surgical interventions done for thoracic trauma patients at NHSL. And you can see there were total 32 patients, and majority were male patients. And the penetrating trauma was much more commoner than blunt thoracic trauma. And you can see the rib fractures and flail segment we operated on 11 patients, and lung injury was seen in 17 patients. And there were some cardiac repairs done on another 7 patients. So here we see some difference with regard to the data that I have shown earlier, that penetrating trauma was much more commoner when it comes to the urgent or emergency surgical interventions done during the period. Obviously, the National Trauma Center, which has the access to both cardiothoracic, as well as the visiting thoracic surgeons coming and serving the station. So only the specialized patients will be referred to the cardiothoracic teams, and then that's why the penetrating trauma are the ones which needed more emergency surgical interventions compared to the blunt thoracic trauma. And then mortality rates were about 9.4%, which was fairly acceptable compared to the injuries patients having. And overall management in these trauma patients, especially blunt thoracic trauma or whatever the penetrating thoracic trauma, the resuscitation ATLS protocols should be adhered. And as you know, the news guidelines of ATLS, so airway, breathing, circulation, and so forth, and you have to follow these ATLS guidance in managing these patients. And then initial management should be done at the A&E and either primary care units, and then depending on the findings or the stability, the specialized management requires cardiac or thoracic surgical teams involvement. And again, depending on the extrathoracic injuries and the injury pattern seen in the chest will be decided when we consider a surgical intervention in these sort of patients. So when you move to the cases, this one of the patients, the middle-aged man, presented following a heavy load has fallen onto the chest and admitted to Badul Hospital, and a patient was having difficulty breathing. As you can see, there's a flail in central chest, and he was intubated and transferred for further management to Accident Service National Hospital, and we did surgical fixation of the comminuted fracture of the sternum, and there were some left-sided chest wall fractures, rib fractures, which we have repaired. And this patient, a 35-year-old lady, pregnant mother on her 3rd trimester, presented following motor vehicle collision, and she was the front passenger of a stationary car where a lorry has struck from behind, and you can see the imprint abrasion of the seatbelt injury, and she had a right-sided manubrium sternal joint fracture along with the part of the manubrium fractured, and right side breast has been degloved, which we repaired using plates, and both these patients went home 7 to 10 days following the surgical interventions. So management principles in chest wall fixation following the ATLS guideline is mandatory, and damage control approach is considered, and definitive surgery for chest wall fixation should be decided by a thoracic surgical team, cardiothoracic team, depending on the injury pattern and other extrathoracic injuries present. The evidence says the early chest wall fixation within 48 hours to 72 hours will improve the overall survival. even with the patient with significant neurosurgical trauma with GCS, very low GCS. So overall survival will be improved with early chest wall fixation. Therapeutic bronchoscopy, chest physiotherapy, fluid balance, and pain management plays a vital role in these sort of patients in chest wall injury management. There's a young girl, 6-year-old girl, presented following a trauma. She was trapped um, in between a fence and a reversing car, and she was trapped there for like 15 to 20 minutes and extracted from the scene, admitted to Hambantota Hospital, and on admission she was having difficulty in breathing and had a respiratory arrest, and they found that she's having a tension pneumothorax. As you can see, they have put IC tubes and transferred this patient for further management to National Hospital. And she did well, and then we didn't have to do any other surgical intervention, and then she went home after 2 weeks staying in Ledridge Hospital. So the hemothorax and pneumothorax combined with chest wall injury and then lung injury are the commonest presentations that we see in local setup. And when it presents, tension pneumothorax should be clinically identified early as much as possible, and tension should be relieved either by putting a wide bore cannula in kids, mid-clavicular line, second intercostal space. In adults, in the safe triangle, you can put the wide bore cannula, and again follow the ATLS guidance. And massive hemothorax, again putting an IC tube, intercostal drain to drain the hemothorax, and the initial drainage more than 1,500 mils of blood is significant. And at the same time, the massive blood transfusion protocol should be activated in these sort of patients in massive hemothorax. And the specialized team or the general surgical team should decide whether this patient needs urgent surgical exploration. And these are life-threatening presentations, especially the A&E teams should be aware about these conditions and then do the active resuscitation and management according to the ATLS guidance, and then refer these patients to specialized management as soon as possible. And again, when we put an IC tube, that is very important to check the drainage and then check whether there's any bubbling, because drainage is very important. If it is persistent drainage more than 150 to 200 per hour in consecutive 3 to 4 hours duration, and then patient is still bleeding and blood pressures are going down, and that may be a sign that we might have to explore this patient in urgent basis. Again, persistent bubbling may be a sign of lung injury, and significant bubbling with desaturation, and even if you intubate the patient, if the patient can't be ventilated properly, that may be a sign of tracheobronchial injury. Case 4, there's a middle-aged man who had a fall and presented with chest pain, difficult breathing, and found to have rib fractures, and initially managed at the A&E and stepped down to the surgical ward. And in the surgical ward, he persistently had this difficult breathing, and then subsequent x-ray showed there's some haziness in the left lower zone, which later found that he was having some abdominal viscera herniated through the left diaphragm into the chest, which was subsequently repaired by thoracoscopically. Again, the management of diaphragmatic and esophageal injury. Diaphragmatic and esophageal injury is very uncommon to be seen in isolated forms following chest trauma or abdominal trauma. Most of the time, these injuries will be seen along with other major organ injuries and in polytrauma patients. So depending on the stability of the patient and then the severity of the injuries having in the abdomen or any other injuries or in the thorax will be considered in deciding for surgical intervention. And diaphragmatic injury can be repaired by open means or by thoracoscopic means, again depending on the nature or stability of the nature of the injuries and stability of the patient. And primary esophageal injury is very uncommon to have isolated esophageal injury following trauma, and most of the time this will be accompanied by other tracheobronchial injuries and other major injuries in the abdomen or chest. And esophageal injury primarily, when it is noted, it can be repaired primarily in some patients. And when it comes to the major injuries which is related to the heart and great vessels, most of these patients in Sri Lankan setup, they will not reach the hospital as due to the exsanguination, and they will die on the scene, most of them. And again, some of these patients will be taken to the hospital in very unstable conditions, especially in case where the bleeding is temporarily arrested due to clot. And when they reach, there should be high degree of suspicion of an injury to the great vessels or the heart, and most of these patients will require urgent surgical intervention, like emergency surgical intervention in the theater. And the tracheobronchial injuries and cardiac injury will be covered later of the day today, so I'm not going to talk much on that. But since we are talking about the emergency room thoracotomy or resuscitative thoracotomy, in other words, pre-hospital thoracotomy, as trainees and as surgeons, you should have some idea about these interventions. And these emergency room thoracotomy or resuscitative thoracotomy, they are mainly done in either A&E or the pre-hospital setup. And so the most of the time this is done in a patient who had a thoracic injury, witnessed arrest, and done on the left side, left anterolateral thoracotomy or a clamshell incision. And mainly these sort of injuries, again, penetrative injuries, and the main goals I'm going to mention in my next slide. So then the studies have shown that when it is performed in a patient who had a penetrative injury with a witness cardiac arrest, so that carries a better prognosis than in a patient we do this emergency room thoracotomy in a blunt trauma patient with a prolonged arrest and all. So in other words, resuscitative thoracotomy or pre-hospital thoracotomy or emergency room thoracotomy, it should be done by a person who has been trained on these interventions. And again, the decision to proceed with this emergency surgical intervention is very tricky, as in most of the time we see some patients following clamshell thoracotomies or emergency room thoracotomy, and then they were referred to our institution for follow-up and all, and then they have more complications because of the clamshell thoracotomy. And then the indications, when we think about these patients, the indications were inappropriate in most of the time. And so it should be done carefully, selected patients, otherwise it carries, it just only add something more to the dying patient. And again, in a patient who has had a long downtime, doing an emergency room thoracotomy or resuscitative thoracotomy, and then even if you revive the patient, stop the bleeding and all, and because of the downtime, you have to consider about the hypoxic brain damage, and whether you are going to survive this patient. So that should be considered in deciding emergency room thoracotomy. And primary goals of this procedure should be hemorrhage control and release of cardiac tamponade, and resuscitative thoracotomy is, in other words, they say, because when we do this, you can do the internal cardiac massage, prevention of air embolism, that because of the opening of the large veins, the air embolism can kill instantly, and again cross clamping of the descending thoracic aorta, and repair of cardiac or pulmonary injury. And so the evidence say, as you can go and check the evidence, and as mentioned here, this was um, uh, done by retrospective collection of the data for a long period from 1975 to 2020 in one of the Western institutions, and according to the data, says most of the time the emergency room thoracotomy or pre-aspirated thoracotomy is not successful, and it should be done in a way that in a clearly designated patients. So in Sri Lankan setup, what I would say is, if one is trying for a emergency room thoracotomy or resuscitative thoracotomy, ideally it should be, I would say, the left anterolateral thoracotomy in a patient with penetrating chest trauma, that we are going to achieve the goals that I have already mentioned in previous slide. And again, a clamshell thoracotomy is the other commonest incisions. So the take-home message with this blunt thoracic injury. So it is a blunt thoracic trauma, is the commonest form of thoracic injury seen in Sri Lanka, and with a proper treatment, these patients will have significant morbidity and mortality. And nowadays, because of this increasing rise of the violence, and the penetrating chest injuries are seen more, and then admitting more to the hospitals, and sound knowledge of this mechanism of injury and is very helpful in managing these patients, and adhering to the ATLS guidelines and damage control surgery principles is mandatory in managing these sort of patients to reduce the morbidity and mortality related to this trauma. And the resuscitative thoracotomy, and which is called pre-hospital thoracotomy or emergency room thoracotomy, should be done by a person who's experienced in the procedure, and the decision to proceed with resuscitative thoracotomy, clamshell thoracotomy, or pre-hospital thoracotomy, emergency thoracotomy, whatever the name it says, the indication and the patient that you are going to do should be decided very clearly. Otherwise, you are resuscitating in a dying patient, and you're not going to gain anything from this the procedure, and then it will be just only an academic endeavor. And our experience is, most of the time, the patients that we see in our center is referred following this emergency clamshell thoracotomies and all. They following the procedure, they had to stay for long time due to the intervention that they had. Recently also we had some few patients like this. So in other words, left-sided anterolateral thoracotomy or clamshell thoracotomy is the commonest form if you had to do this procedure to achieve the goals that I have mentioned. And thank you for listening about this lecture. And I have checked some of the questions which will be important for you guys in preparation for the coming exam. And this is one of the other goals. I mean, you should know how to manage these patients in practical setup, and again, the passing the exam is one of the important things. So these questions were extracted from one of your senior colleagues and all, and maybe the stems and the question answers and maybe not 100% correct, but you have to think about uh, the way that how they ask questions in the exam. So here is one of the questions, if you can read, and regarding one of the patients who presented with road traffic accident with a crush injury and saying having difficulty breathing with flared chest and asking for a next best management. So always read the stem carefully, and they're asking about the next best management. So what do you think? So there are 5 options, and I would say according to the given history and all, intubation is the most best management when we consider about the um, uh, about the answers that they have given. This one again, a male stabbed to left anterior chest and above the nipple, and hemodynamic instability, and emergency room thoracotomy decided, and then they're asking about the incision. These sort of questions are, I mean, tricky, because sometimes there may be 1 or 2 answers definitely in at your level. One can say either median sternotomy is better, left anterolateral thoracotomy is better, and bilateral thoracotomy, but still, I mean, even clamshell, but they're asking what is the approach. So I would say at your level, in this question, we had to go for left anterolateral thoracotomy. Another one, 21-year-old male, again stab wound, anterior chest wall, and hemothorax, chest drain inserted. And again, they're asking about the reason if you are going for an emergency thoracotomy, that is taking the patient to the theater. Again, like here, you have to follow the ATLS guidance, and ongoing bleeding 150 to 200 mils per hour, 3 to 4 hours. More than that, that is a significant amount, and more than 1500 immediate drainage, again significant. So I would go for like more than 1500 immediate chest tube drainage is maybe an indication. And yeah, one can argue that ongoing bleeding at a rate of 100 mils per hour, but we have to find the best answer for this. I would say it's C. Again, young patient and fallen from height. Given the parameters, IC tube inserted, and pain relief was given, and it shows that blood pressure is fine. Respiratory rate is elevated, pulse rate is high, saturation 95, and asking for the next step in management. So this is a trauma setup, and the hemodynamic stability is fairly okay, and they're asking the next step in the management. So I would say thoracotomy, there's no indication to do thoracotomy, and MRI is not an indication in trauma setup. And so whether it's to go ahead with the CT or the X-ray or ultrasound scan is the debate. So if the patient is hemodynamically stable, we would go for a CT scan, CT chest, maybe a trauma CT, trauma protocol. That will be the best in the management. So again, extended matching question. These sort of questions, when you encounter, just try to read through the instances, like they're asking. Okay, first one is shotgun injury to the chest, abdomen, with a sucking thoracic wound, transferred with left intercostal tube with an initial drainage of 250 with some more drainage, and they have the pulse rate is high, blood pressure is low, and they're asking what is the next step of the management. And the important thing is, like, there's a sucking thoracic wound. Again, IC tube inserted, and then initial drainage 250, not that much, but pulse rate is high, blood pressure is going low. So what do you think? So they're asking for the best management. So the second one, 35-year-old patient following road traffic accident, underwent laparotomy and 4-quadrant packing, but oozing from the right upper quadrant, noted. And the third one, I mean, second one is not related to thoracic. Third one in a trauma, laparotomy again, it's not directly related to the chest, but the first one, chest and abdomen, I would say the patient with a shotgun injury, chest, abdomen, and sucking wound, and there may be abdominal bleeding, and there may be chest bleeding. So we can do clamshell thoracotomy, and lateral thoracotomy. Again, damage control laparotomy, and thoracotomy and aortic control. So all those, and postlateral thoracotomy. So I don't know the exact answer, but in these sort of questions, maybe now these questions they were written by your senior colleagues. Sometimes the stem and then answer, some of the parts are missing. So don't try to follow the exact answer when it comes to these sort of questions when you are doing revision, but you have to get the objective and the idea. So so the idea of these sort of question is to find out in this damage control approach, what are you going to do when you encounter these sort of patients. Now here, the main thing that you have to consider is like the bleeding, shotgun injury into the chest and into the abdomen. So there may be bleeding into the chest or bleeding into the abdomen, and so you have to control the bleeding. So shotgun injury, multiple pellets in the abdomen, chest, and to stop the bleeding, and then packing or control the bleeding. What is the best approach? So clamshell thoracotomy, because it doesn't say any site. So one option is a clamshell thoracotomy, and try to pack the chest, control the bleeding. If there's any uncontrolled bleeding in the abdomen, again, descending aorta can be cross-clammed. So that would be the best answer in that scenario. But as I said earlier, now these sort of questions prepared or written by your senior colleagues may be missing some part of the question, maybe some part of the stem. So don't go behind the answers and all, but you have to think about the principles. So that is the thing that they're asking. So when there's two cavities are involved in bleeding, what is the best single approach you can have to stop the bleeding? So if you go from the chest, yes, you can do the descending aortic clamp, and then that will temporarily stop the bleeding from the abdomen till you go inside and then pack or do the bleeding control from the abdomen. So that is the principle that you have to think of when you come to a question like this. Again, here some EMQ, the best answer, the options they are giving. Chest impact, cricket ball 1 day ago, and then breathlessness on exertion, local pain, and tender with crepitations, and hemodynamic stable with normal SpO2 and ambient air. So there's a history of chest trauma, blunt chest trauma, and difficulty in breathing, and hemodynamic stability is there. Saturation is normal with in normal air. So here, the pain relief is the main component, and then he's not breathless, saturation is fine. They're asking about the pain relief that you can give in the hospital setup, and that is the thing that they are checking in these sort of questions. The next one, high velocity road traffic accident, driver died at the scene. So that gives you the gravity of the trauma. and left side chest pain and shortness of breath, trachea deviated to the right side. So left side trauma, trachea deviated to the right side, signifies some tensioning on the left side. Left side is not expanding. Again, neck veins distended, so that warrants an IC tube insertion to the left side. Looks like tension pneumothorax. Again, blunt trauma, anterior chest, sternal region, trachea midline, bilateral entry, blood pressures, marginal, pulse rate high. The next management option, anterior chest, trauma, sternal region, that this may signify chest injury, chest contusion, and they're asking the next management option. I mean, there may be an underlying hemothorax, pneumothorax, again, cardiac contusion, and pericardial effusions. So one option is to, they're asking about the next management option. So troponin I, not significant at this stage, 2D echo and 2 LED ECG. You can't come to a definitive diagnose or insight what is going on with this, but either CT chest or an EFAST would give you an idea. So an EFAST would give you an idea about the pericardial effusions, pleural effusions. So that would be the best in A&E setup since the patient is like marginally stable one. But again, CCT in a stable patient, CCT would give more information. Right-sided pneumonectomy done for traumatic hilar bleeding, best management option of the IC tube, and again, like for hilar bleeding, these sort of questions are highly theoretical. As in a trauma patient, when there's a hilar bleeding, very unlikely to survive till they, unless it's like clotted and then bleeding has been stopped. And again, in a trauma setup, with all the physiological response to trauma and right-sided pneumonectomy done in a trauma setup, there will be a lot of physiological changes, and there will be a lot of problems going on in these sort of patients. So actually, these highly theoretical question, I would say, I don't know who has put these sort of questions, but since if they put a question like this, and so they're asking about the IC tube management, and I would say we're definitely following a pneumonectomy. We have to keep the IC tube in at least minimum 24 to 48 hours. And there's a protocol that we use in Varisara, the clamping and unclamping of the IC tube following a pneumonectomy. And so IC tube should be in. You can't close without an IC tube in a trauma situation. So these sort of, in my opinion, these sort of questions should not be put in this level, because having a right-sided hilar injury and doing a pneumonectomy is very uncommon in practice. 60-year-old patient with COPD, should be COPD, I think, presenting following road traffic accident and left side chest pain, dyspnea, cyanosed, left side flare segment, and they're asking the most appropriate management. So the question is, there's a flare segment and he's cyanosed. Now COPD, there are two types, pink puffers and blue bloaters, and then the cyanosis and respiratory rate, high respiratory rate may be due to COPD. But when a patient is having COPD, old age, with a flare segment that impair these sort of patients' respiration furthermore, and so the most appropriate management they're asking, and I would say the most appropriate one would be like early fixation in these sort of patients, rather than intubation and ventilation. So, but if in practical world, if we see these sort of patients, we would decide on early surgical intervention, fixation, and then as a part we have to intubate and ventilate and do the surgery soon. And then wean off these sort of patients as soon as possible. So I would say fixation is the best option rather than keeping the patient intubated and ventilated. Again, young patient, left upper blunt injury, dyspnea, again left upper abdomen, dyspnea, and then respiratory rate, blood pressure, tracheus midline. So again, the history, left sided air entry is reduced. So left upper abdomen can be associated with left-sided hemothorax and maybe diaphragmatic rupture. So according to the history, this is more suggestive of a diaphragmatic rupture to me, but only 4 stems are there in your past papers and all, but they say it's abdominal trauma, so I would go for diaphragmatic rupture. High velocity collision, again driver dead. Again, asking for the distended neck veins, best management. Again, that side should be decompressed. Again, road traffic accident, parameters given, pneumothorax, no hemothorax, minimal 10 to 15, rib fractured, again, flared segment, and they're asking what to do. Now, there's a mechanical problem because of the flared segment, and there's a pneumothorax, and lung contusions, blood pressure stable but pulse rate high, respiratory rate high. Asking for the best management in this patient. It's like, you know, these sort of question even for us, like sometimes it's a bit tricky because they're depending on the person who's putting these sort of questions, and I don't know whether this has been put by cardiothoracic or thoracic surgeon. So if this is a young patient, so the rationale I can explain, the pneumothorax is on the left side, and again I assume that the same fractures are on the on the left side. So young patient having a pneumothorax, then I would say, like, first we'll decide on whether there's a need for refixation and take the patient to the theater and then do the refixation, putting a tube afterwards, and then this patient recover very well early if we can do it early as an early intervention. And elective ventilation, not a good option. Strapping, again, not a good option. Corset and analgesia, yeah, can do, but the problem is there's a pneumothorax, which is not the best option. So fixation, I would say, is the best for me. Thoracic trauma is again hypertensive, engorged neck veins, and entry, reduced entry, bradycardia with broad QRS complexes. So, like, again, features of heart sounds muffled, so cardiac tamponade may be having some features of pneumothorax, more towards like I would say now hypertensive and engorged neck veins. The features are there, like to say, like again bradycardia and broad QRS complexes. Again, like a tricky question, these sort of question which is not clearly saying direct into one side, but hypertension and engorged neck veins can happen following tension pneumothorax, and again cardiac tamponade can resulting in poor heart filling, and that can resulting in engorged neck veins, again hypertension. And air entry reduce is the main component that you have to consider. So I would say putting IC tube would relieve this tension pneumothorax. And yeah, again, blunt trauma, again, same sort of questions, multiple fractures, and best mode of management, and pneumothorax, again, like similar type of question. And rib fixation, I would say the best option. So likewise, now we have discussed some of the questions and all, and then we can go forever like this. And these questions you can see mainly based on the thoracic trauma when you go to the exam, and so you have to be thorough with the trauma protocol, ATLS, and because that will be asked and assessed in the exam. And acknowledgement for Dr. Shehan, who has helped me in finding these questions and all, and good luck for the exam. Thank you very much for listening.
Thank you, Saman, for your excellent presentation and all the elaborative discussion about all the past questions. And it is time for the questions. If you have any questions, someone is online and he's ready to answer your queries. Someone, can you hear us?
Yes, yes,
All right.
I can hear. I think we have covered like the basics of the mainly the blunt thoracic trauma, and and then subsequently Dr. Asnaik and Dr. Aravind will be covering the rest of the topics. But if you have any questions, you can ask now. And because as I have mentioned, there are a lot of questions asked in the exam, mainly related to this thoracic injuries. And I tried to give you guys an insight what is how they ask the questions in the exams, and the most important thing is follow the ATLS guidance, and then read the whatever the guidance or the booklet on ATLS, and then that will give most of the answers for your questions.
Thank you very much, Saman. As there's no question from the audience, we'll move to the next topic. Next topic will be the principles of management of cardiac trauma by Dr. Aravind. It's over to you, Aravind.
Thank you, Rasnaika sir, for that kind introduction. Good morning to all of you. Today I'll be giving a talk on principles of managing cardiac injuries, which is a quite uncharted territory for a non-cardiac or non-cardiothoracic surgeon. So, but I'll be taking a practical approach so that you have some insight and do further reading. Where if you find or encounter a cardiac trauma patient, you will have some insight into what to do and what not to do. Okay, so the outline of the presentation would be introduction, epidemiology, a few bits of epidemiology, an initial approach and assessment, formulating a management plan, and mainly I'll be concentrating on management of penetrating cardiac injuries. These are the three main concerns we should think when faced with a patient with cardiac trauma. Whether it's a blunt cardiac injury or whether it's a penetrating cardiac injury, because the underlying cardiac trauma or the cardiac lesion would be quite different in the two injury mechanisms. And subsequently, the management protocols and management options would be different as well. And whether it's isolated cardiac injury or whether this is a part of a polytrauma patient. And most importantly, the hemodynamic stability of the patient, which will dictate how the patient is investigated and how the patient will be further managed. So these are the main considerations. Keeping this in mind, so basically it's an injury with high mortality rates. Approximately 20% of patients who sustain a thoracic injury die because of a cardiac injury. And half of all patients who sustain the cardiac injury will die at the scene, and another close to 30 to 33% will die during transport. So that's close to 80 to 85% will perish and succumb to their injuries, to their cardiac injury, and only 15% will survive to reach the hospital. So out of those 15% of patients who survive and arrive at the hospital alive, there's about 50 to 65% percentage of patients will survive to discharge. So that's again, there's a 40% mortality in hospital mortality rate. However, if we timely intervene, we can salvage these patients. So as surgeons, as trauma surgeons or general surgeons in a peripheral hospital or a major hospital, so what most important thing is how we approach a patient and how we assess a patient with cardiac trauma or polytrauma. As we all know, it's always according to a TLS protocol, primary survey and secondary survey. Patient with a cardiac injury would always have to a primary survey with ongoing resuscitation would have to take place. So when considering cardiac injury per se, the most important pathophysiological condition that would occur, which we can immediately intervene and reverse, is acute cardiac tamponade. Other injuries such as valve injuries, septal injuries, coronary injuries, I mean, they can't be immediately addressed. So the most important pathophysiological thing that we need to understand is acute cardiac tamponade with regards to damage control principles. That is the thing that we can immediately intervene and salvage patients. So as we all know, Beck's triad, hypotension, engorged neck vessels, and muffled heart sounds are the classical triad of acute tamponade. However, these classical symptoms, the classical triad is only seen in about 10 to 20% of cardiac injury patients due to many reasons. Because it could be confounded due to ongoing hemorrhage. In that case, patients will not have engorged neck vessels because patient is hypovolemic. And the patient will have tension if the patient has a tension pneumothorax, the patient will again have engorged neck vessels and hypotension, but not due to cardiac tamponade. And they can have both. So it's just we have to go clinically And according to ATLS protocol, if you go according to A, B, C, D, E, airway, breathing, and circulation, we will be addressing all these things properly and effectively. And another thing that is important is pulsus paradoxes, where you will feel when you feel the pulse, there will be the pulses would be of different intensity according to your inspiration. That is how the feeling the radial pulse, you can appreciate that during a trauma setup, because you won't be able to in a trauma setup when resuscitating a patient, you won't be able to detect this with measuring the blood pressure, but you would definitely, I have felt this phenomenon of appreciating the radial pulse at different intensities during the respiratory cycle. And another important thing is to identify that if the patient doesn't have significant bleeding and is not pale, but hypotensive and tachycardic, there is shock. And then the initial kind of inclination is to give fluids, resuscitate with fluids. But then you would see that the patient does not really respond to fluid. In that case, then you should quickly think whether this is an obstructive type of a shock, acute cardiac tamponade, or tension pneumothorax, right? So tension pneumothorax, if you see the chest and auscultate, you would quickly see that there's reduced air entry. So that can be quickly reversed by, quickly addressed by doing a finger thoracotomy, quickly do a decompression of the chest. And if that is the cause, the hemodynamics will drastically improve. If that is not the cause, if there's no tension pneumothorax, then more likely it is the cause obstructive shock due to a cardiac tamponade. So that can be kind of confirmed by a fast scan, which is 90 to 95% accurate in diagnosing acute pericardial effusion or hemopericardium with tamponade. So that is an important practical point that we need to understand. Otherwise, we'll end up transfusing 2 liters of fluid, and massive transfusion protocol will be activated because the patient is in shock. However, it's not a hypovolemic shock. It's an obstructive shock. The management is different. So I have experienced this as a registrar myself, and I have learned it the hard way. So that is something that you need to keep in mind. So after the initial approach, the most important thing is to identify very quickly what is the patient's hemodynamic stability. And depending on that, we proceed with investigations and management. Patient could be very stable so that means the primary insult has occurred. There's no ongoing insult. Patient is stable, is all right. So you have time to investigate. The other patient is stable with possibly an ongoing insult, ongoing bleeding or something, but patient, it's not a major injury. He's compensating, and he remains in a compensated situation. So these 2 patients populations can be investigated with a EFAST or a CECT chest, depending on the availability of resources. The unstable patient is the next population of patients where you need to act quickly to decide what needs to be done. The other extreme is a patient in peri-arrest, or a peri-arrest situation where there is a ready pulse, but the next 2-3 minutes or the next 5 minutes, patient will arrest, or a patient with trauma. Patient comes to the trauma unit arrested or a witnessed arrest. So peri-arrest untraumatic cardiac arrest is a different entity where you need to go down a different management protocol. So like I said, fast is the most important thing in cardiac trauma. It can kind of give you an initial assessment. It's quite quick, readily available, but it's operator dependent, as you all know. But it is quite a good tool to have. So if time permits, CT chest you can do for the stable patients, but not for the other 3 patients. So echocardiography, transthoracic or transesophageal, ECG, cardiac biomarkers, and radionuclide angiography are mainly for patients with blunt cardiac injury to detect cardiac contusions and myocardial dysfunction, valvular injuries, and all that. So basically, we will be concentrating on the management of penetrating cardiac trauma. So So now, after the initial assessment, there are a few things that you need to quickly decide on. Is there a cardiac injury? Is it confirmed, or is it confidently ruled out? That again is a clinical as well as a clinical judgment, as well as whatever the EFAST or the CCT chest will assist in confirming this cardiac injury, confirmed or not. So after that, does the patient need operative intervention? If it's peri-arrest or traumatic cardiac arrest, penetrating cardiac injury, yes. If there's cardiac injury, you need operative intervention, which is an emergency thoracotomy. If not, if the patient is stable, according to the cardiac injury, you can go for an urgent. If the patient is decompensating, you can go for an urgent intervention. Or if the patient is stable, you can opt for elective. So that is something that you need to consider. The other important thing is, as general surgeons, what we need to think about are temporizing measures or other diagnostic procedures that we can do to kind of evaluate the situation further. Pericardiocentesis, image guided or blind, could be done, or pericardial window and pericardial lavage. So pericardial window is something I think we should, as general surgeons, we should not be afraid to perform a pericardial window, because mainly a subsiphoid pericardial window, because general surgeons are quite familiar with the epigastric region. So it's like dissecting for an epigastric hernia, but you just have to go a bit deeper. And if you properly understand the anatomy, it's a very straightforward and simple procedure, which can actually save a patient's life, temporize and stabilize until you can transfer the patient to a cardiothoracic unit, or you can call for expertise. And there are other ways in which you can do a pericardial window, thoracoscopic or through a mini thoracotomy, or you can do laparoscopically if you have to explore the abdomen. If there's a suspected injury in the pericardium, you can do a transdiaphragmatic pericardial window through the laparoscope, or as an open technique. Make a small incision and do a small pericardiectomy on the central tendon, and you can leave it open. There won't be any adverse sequelae of leaving the small opening in the central tendon. But that will again give you a diagnosis, as well as it could be therapeutic as well sometimes. So that is one option that you can have. The next consideration is the patient stable enough to be transferred to a specialized center? From the onset, if the patient is stable, early liaison with the cardiothoracic team is advised. But if the patient is not stable enough for all that, you should bite the bullet and go ahead with the intervention which necessary to save the patient. So this is a schematic representation of how to do a subsiphoid pericardiotomy. In practical terms, you make about 6 to 7 centimeter incision centered on the ciphisternal joint, go upwards and below maybe 3-4 centimeters, and then incise the linea alba onto the xiphoid process, and then extend the incision upwards and towards the rectus sheath, and then you would see the xiphoid, then place a mastoid self-retaining retractor or whatever type of retractor to keep the wound open. After that, slightly go beneath the rectus, posterior rectus sheath, where you will find fatty tissue. Do a finger dissection and run your finger on the posterior aspect of the xiphoid process and bluntly dissect it downwards towards the diaphragm. There'll be a bit of tough tissue there. That is the sternal attachment of the diaphragm to the xiphoid. That has to be pushed down. And once that is pushed down, you can use a heavy scissor to cut the xiphoid process. And that is all that you need. And then you put a retractor towards the ciphisternal joint. You can resect the xiphoid or just split it. Retract the sternum, the body of the sternum upwards, and then do a blunt dissection until you see the fibrous pericardial sac. And then you grasp it like opening the peritoneum. You can grasp it with two swordtails or mosquitoes and carefully incise. And that is if you do it carefully, it's a very safe procedure, which can be done from skin to entering the pericardial sacs maybe in 10 minutes if you're so, and that will help to maybe save that patient or to temporize and stabilize the patient and transfer the patient. So once you do that, you can do a pericardial lavage, instill a warm normal saline and suck it out and place a tube through a separate stab incision and close the wound and transfer if needed. So this is like for your hepatic and renal and splenic injuries. This is a American Association of Surgery of Trauma heart injury scale, which is very detailed. You don't have to read it at all. I just put for your information. Heart injuries are also classified according to a graded scale. So this is for research purpose and all that. I don't think you will be asked about this at any point of your exam. So don't worry about that. So going into penetrating cardiac injury, as we all know, most commonly it's the stab injuries and then gunshot injury. And another important etiological factor is the impalement injuries, where you get accidental impalements, like falling onto a sharp object or accidentally being kind of impaled by a sharp object. And other thing is iatrogenic injury, maybe during surgical procedures or catheter-based work. There could be penetrating cardiac injuries. So few important principles in managing penetrating cardiac injuries. Like I said, when you consider cardiac injuries, it's blunt cardiac injuries versus penetrating cardiac injuries. Penetrating cardiac injuries, the important thing is when there is a precordial wound in a location and direction that could involve the heart, the assumption is made that there is a penetrating wound of the heart. So until proven otherwise, we work with the assumption that there is a wound, and then we actively do things, investigate to either confidently say there is a cardiac wound or there is no cardiac wound. We have to be confident about that. So that assumption is made until it is proven so. And the other thing is, other important, you would already know this, if the penetrating device is still in place, stuck in the chest or in the heart or whatever, even if it is beating, you don't take it out, you don't pull it out until the patient is taken into theater, anesthetized, and a surgical access is taken and the pericardium is open, because that probably the patient is alive and with the device in situ, there's no ongoing insult. Everything is kind of settled. So you don't want to make matters worse by pulling it out, right? So during investigation, CT, you have to accompany the patient, make sure that, the staff is careful enough to not displace it. So it's quite hard work, quite terrifying to the patient as well as the staff, but that is how it should be done. Please make sure that either you or one of your experienced staff members accompany the patient and, to the investigations and return back safely, because the patient came to the hospital alive, and I think we should be able to send the patient alive after sorting the problem. So that is an important principle that we should keep in mind. And again, the management strategy of penetrating cardiac injury patients depends on the hemodynamic stability of the patient and extent of the penetrating cardiac wound, which will be kind of gauged by obviously the hemodynamic parameters and the presence of a pericardial effusion. So in terms of incidence, the right ventricle being located anteriorly in the chest is the most commonly injured, 35%. After that, it's the left ventricle to the left or the right ventricle. And in 30% of patients, multiple chambers are involved in cardiac injury, penetrating cardiac injury. So as we all know, yes, any structure of the heart can get involved, can be damaged with penetrating cardiac injury. So what we as general surgeons in a damage control setting can address is injury to free walls, the anterior wall or the lateral wall, which is the RA, RV, and the LV. it's very rare for the posterior heart surface to get stabbed, but it can happen, but very rare. Likewise, but there could be, but we have to keep in mind, there could be cardiac septal, intra-atrial in interventricular septal damage with stabs. Cardiac valves could be damaged. Coronary vessels could be stabbed and damaged and cause myocardial dysfunction and ischemia and dysfunction. And there could be associated great vessels injury as well. So priority is to save life, obviously, in this setting. Stick to damage control principles and proceed. So, like I said, all coronary lesions would need bypass grafts. Cardiac valves and septae would need, cardio institution of cardiopulmonary bypass and proper reparative procedures. So all these things can't be done at the damage control setting. They could be done if the patient remains stable. Better to delay them for about 8 to 12 weeks. Once the patient is stabilized, the acute problem is settled, then a proper, more longer lasting repair can be done after about 8 to 12 weeks if the patient remains stable. If not, so even if you do a damage control surgery and control the bleeding from the external surface of the heart, the patient's hemodynamics might not improve if there's underlying coronary injury, or if there's a underlying acute severe MR or a caudal rupture or a papillary muscle rupture causing an MR. If there's a ventricular septal defect which is causing a massive shunt and pulmonary hypertension, the patient might not recover from that. So in that case, that is why it's important to, liaise with the cardiothoracic surgical team to kind of plan out the further long-term management if there are associated injuries. But if the patient, definitely the patient would need proper follow-up after the initial damage control surgery. So, yeah. Again, like I said, there's a spectrum of how the patients would present, and after the initial assessment, we would know what we are facing. Depending on the stability, patients should undergo imaging again, fast and CCT chest. In stable patients, so the initial two patient populations, stable with no ongoing insult and stable with compensation, you can do a fast scan. And the severity of the hemopericardium, which is mild, which is rated as mild, moderate, or severe, and the presence or absence of cardiac tamponade. If the patient is collapsing, is in persistent shock, that will dictate how we manage the patients, right? The severity of hemopericardium and the degree of if there's cardiac tamponade or not. So patients who are unstable to undergo imaging, they are not peri-arrest, but they're very weak pulse. You're not sure that he's going to survive for another 5-10 minutes or maybe 20 minutes to undergo a CT chest. Fast scan is the only thing that you can do. Fast scan, even you might not be able to do a fast scan. So in that case, there's no point in wasting time in trying to do unnecessary investigations. Best thing is to wheel the patient into the theater where you have instruments and equipment and the theater is ready. So you can do a proper exploration via an anterolateral thoracotomy or a median sternotomy, depending on the injury pattern. So, and the peri-arrest and traumatic cardiac arrest patients should undergo emergency room resuscitative thoracotomy, because this is where you get the best results from an emergency room thoracotomy. Penetrating cardiac injury, witnessed arrest is the best, but different guidelines and management protocols say within 5 minutes or within 5 to 15 minutes. Some even go up to 15 minutes of traumatic cardiac arrest. The patient was arrested 15 minutes ago. If it was a if it is a penetrating cardiac trauma, some institutions recommend performing a resuscitative thoracotomy, because patients sometimes can be, because there are case reports where the patient has survived with good neurological outcome. After 32 minutes, patient has been arrested for 32 minutes. So that's an extreme case. But because of these things, some institutions say even if it is 15 minutes for a penetrating cardiac trauma, you go ahead with a emergency room thoracotomy, because otherwise the guaranteed outcome is death if you don't do it. guaranteed outcome is death. So if it is a penetrating trauma, you go ahead with a emergency room thoracotomy, resuscitative thoracotomy, to see if you can salvage the patient. If not, if the patient does not come back, you obviously, after about 25 minutes, you can stop the procedure. So blunt trauma is different. Blunt cardiac trauma is different. Blunt cardiac trauma, witness arrest only, you would do a resuscitative thoracotomy. But otherwise, you would not do a, if it is blunt cardiac trauma causing a traumatic cardiac arrest, there's no place for out of hospital traumatic cardiac arrest to be opened up in the hospital. Yeah. So this is the surgical management algorithm for penetrating cardiac trauma. So basically, we do, according to your ATLS protocol, you do your initial assessment. If the patient is hemodynamically not stable, you take him to theater, median sternotomy or left anterolateral thoracotomy. What they recommend is, if the patient has the penetrating wound between the nipples, a median sternotomy, if possible, is the best approach. If there is expertise and equipment, and if it can be done, that's the best. And if the penetrating injury is lateral to the nipple, to the left of the nipple, you can consider anterolateral thoracotomy. So that's a recommendation of trauma surgeons. Yeah, and in the patients who are stable, so this is patient, you take the patients who are unstable, decompensating, no time for investigations, straight to theater, either median sternotomy or left anterolateral thoracotomy. So I'm still talking about the decision-making process and the approach to the chest. I'll come once you enter the chest, when you enter the pericardium, what you can do is the next thing, but I'm still saying, I'm still going through the process of, decision-making and managing devising a management plan, right? So in the stable patients, you do a fast, obviously. You do a fast, and if possible, do a CT chest, contrast CT chest. If the fast scan is negative for a hemopericardium, and then that means that unlikely there is a cardiac injury, then you repeat another fast scan in 6 hours. If there's no there's no development of a hemopericardium at 6 hours, you can confidently rule out a cardiac injury. So, and you have to clinically correlate as well. And if the patient has a small or a mild hemopericardium, so the fast scan detects a hemopericardium which is less than 10 millimeters, and no associated hemothorax, and patient's cardiovascular status is stable. There's no features of cardiac tamponade, right? But there is hemopericardium. So even if there is a penetrating cardiac trauma in the precordium, yeah, and there is hemopericardium, that doesn't mean you have to take the patient to theater, right? So these patients can be observed in the ICU setting with serial ultrasound scans, 6 hours, 12 hours, and 24 hours, to see if there is development of or progression, not development, progression of the hemopericardium. If the hemopericardium progresses over time, that means there is an ongoing insult, ongoing bleeding. And then if that is the case, if that is the case, patient should go to the theater for exploration and control of bleeding. Sorry, yeah, to go to the theater. And the recommendation is you can perform a pericardiotomy depending on the other associated injuries, whether it's subxiphoid. If there's associated pleural injuries, it could be thoracotomy. If it's an isolated injury, it could be subxiphoid. With associated pleural injuries, do a thoracotomy. If it is associated with abdominal trauma, if you want to do the open the abdomen, you can first do a open the abdomen. You can pack it and do that as well. Observe the abdomen. You do the abdominal part as well, and then you do a pericardial window through the diaphragm, because the concept is you might be able to avoid a median sternotomy or a thoracotomy by doing a pericardial window and lavage. So basically, if the patient, now the mild pericardium progresses into a moderate or severe, which is 10 to 20 millimeters is moderate hemopericardium, more than 20 is a severe hemopericardium. So these patients should go to theater, and you can initially do a pericardial window and do a lavage and see. You wash the pericardial cavity, suck it out, and see if there's continuous bleeding. If there is continuous bleeding, that means patient needs a definitive reparative procedure. So that is how you proceed. If it remains mild, patient can be observed clinically and then discharged without further intervention on the chest, right? Yeah, if the pericardial window is positive for blood, subsiphoid or whatever the approach, you do a pericardial lavage. If there's continuous bleeding through that window, you do a median sternotomy or a left ventral thoracotomy, right? Yeah. So, like I said, moderate or severe hemopericardium, pericardial window, or pericardial window and lavage. If continuous bleeding, you take him to you proceed with a median sternotomy or an anterolateral thoracotomy for definitive repair. So, like I said, unstable patients, there's no place for pericardial windows and stuff like that. You have to quickly go in and achieve hemorrhage control. But if there is no expertise, and if you want to temporize and transfer the patient, there is a place for pericardiocentesis, a needle pericardiocentesis, or a pigtail catheter insertion. Or you can, if a general surgeon is not very comfortable in doing a full thoracotomy, a subsiphoid pericardiotomy and drainage is also reasonable as a temporizing measure. But the ideal situation is you should go in and do a thoracotomy or a median sternotomy. But because this is an acute cardiac tamponade, even 40 ml of blood aspirated will drastically improve the hemodynamic status of the patient. Peri-arrest, like I said, peri-arrest or traumatic cardiac arrest, resuscitative thoracotomy is indicated. So basically, like I said, now we've gone through the patient assessment, gone through the decision-making process, whether the patient should go to theater or not, what can we do, all that. So depending on the stability and the hemopericardium severity, we should, and the location of the wound, we should decide on the surgical axis, whether it's a median sternotomy or left ventral thoracotomy or a clamshell thoracotomy. So basically, left anterolateral thoracotomy actually is a much faster and maybe a more familiar approach to general surgeons. So even if the wound is in the midline, if you don't have facilities to do a median sternotomy, you can do an anterolateral thoracotomy and extend it into a clamshell. So these are all practical decisions that you have to, real-time decisions that you have to make. But obviously, for an isolated penetrating cardiac injury, even if polytrauma, but there's a definite cardiac injury, median sternotomy is the best approach. If you can do it, you should do it. So it's important that in your surgical training, you come to the cardiac theaters and see how a sternotomy is done. Get the feel of it, see how tissue planes are opened and all that. So when you're faced with these situations, you're not totally going into uncharted territory. You have some familiarity, right? So once whatever the access, median sternotomy or left ventral thoracotomy, you will be encountered with the blood-filled pericardium. If there is blood, you will see a purplish reddish hue. So if it is anterolateral, you have to open the pericardium longitudinally above the phrenic nerve, and you have to definitely place traction sutures, not at the initial setting, but for your definitive repair. Initially, you should open the pericardium, quickly suck out the blood, and then, like in laparotomy, quickly suck out the blood and digital compression, use your digital compression to achieve hemorrhage control. So these are the things. Now, once you have gained access into the pericardium, these are the things that you should be doing. You should think about these things, and these are the options that I have. If I open a pericardium, these are the things that I can do, right? Yeah. So suck out blood and achieve hemorrhage control. So achieving hemorrhage control, ventricular wounds are best done by digital compression. If digital compression is difficult, or if you want to free up your hands, insertion of a Foley catheter and inflating the balloon to 5 to 10 cc is a very good option. And you place gentle traction to close the wound. There's another important advantage in this technique where you can use the Foley catheter to rapidly infuse volume into the ventricles or whatever the ventricles, yes. So that is an added advantage. You can use this Foley catheter for volume resuscitation. So you should never try to place clamps on the ventricle because it can extend and further do damage to the ventricular muscle. So atrial wounds, atriums are quite thin walled, so you can safely place a Satinsky clamp. That's the best. It's very difficult to you can pinch the atrial laceration and control bleeding, but placing a Satinsky clamp frees your hands up, and that can be done, easily achieved. So you then, once you have achieved clinical hemorrhage control, then you think about how I'm going to repair this bleed, this laceration or cut or whatever of the heart, right? Yeah. So this is a schematic representation. Yeah. The other thing that you can do is you can, if you can't really see, you can put 2 parallel sutures, silk or nylon, take quite deep bites, make sure that there are no coronary vessels, and cross it that so that the wound temporarily closes. Then you can devise a plan to close the wound, right? So once all that is done, maybe you might have to do this in the R room, and then keep that if the patient remains stable. Yeah, once you achieve hemorrhage control, the important thing is to transfuse blood, make the patient's blood pressure, resuscitate to proper hemodynamics parameters until you achieve reasonable hemodynamic status. And then if it is a minor repair, you can do it at the R room, or if you have to go to the theater, if you have done an emergency, you can keep the digital pressure and or a Foley catheter, and if you're happy with the stability and the closure security of that temporary closure, you can take the patient to the theater while maintaining that temporary closure, and do a definitive repair at the theater. So hemorrhage control with skin stapler is quite controversial, but that can be done. That can be done if you don't have anything else, and if you want to this thing. It's a very kind of it's quite frightening to put skin staplers on the muscle. So, but it is described in the literature. So what are how would you repair ventricular wounds? So you try to use pledgets wherever possible, either Teflon pledgets, or if you don't have Teflon pledgets, use pericardial, cut strips of small pieces of pericardium and use it as pledgets. Otherwise, the sutures will cut through cheese wire and cut through the myocardium. So always ventricular wounds has to be pledgeted. Unless it's a small superficial injury. If it's a full thickness injury where you have to take deep bites for more robust closure, you have to definitely use pledgets. In a tertiary, in a peripheral center, if you don't have Teflon, use pericardial pledgets, right? It's 2O or 3O polypropylene, round body needle. It has to be quite a big needle, maybe about 20 millimeter or 21 millimeters, for a safe passage of the to safely curve it through the muscle. Wounds adjacent to a coronary artery, you have to make sure that you go beneath the coronary artery, because coronary is epicardial. You have to go beneath the close the wound, going beneath the coronaries. I'll show a picture later. So one more important thing is practical consideration is when it's really difficult to place sutures in a fully filled and a beating ventricle. It's really one thing. It's difficult. The other thing is it could be a dangerous thing, because you might extend the laceration or the cut while trying to do so. So there's a technique described called the inflow occlusion on beating heart technique. You might have to resort to that to do a safe repair. So what is this inflow occlusion beating heart technique? So this is a technique where the cardiac surgeons used before the advent of cardiopulmonary bypass to do certain quick procedures on the heart where they have to open chambers, like tricuspid valve vegetectomies and taking out foreign bodies and things like that. So, but now it's not used that much because of the cardiopulmonary bypass. So how do we do this inflow occlusion? So the aim of inflow occlusion is to empty the heart and make the heart a bit bradycardic, so that you buy some time to do a effective repair. So how do you do it? Is you hyperventilate with 100% oxygen for about 5 minutes to make sure that patient is well oxygenated. And then you occlude both the inferior and the superior vena cava with vascular clamps, long vascular clamps. And then that will inflow, that would reduce the inflow. The RV will empty, RV will empty, and you allow the heart to beat for about few beats, maybe 4, 5, 6 beats, and that will empty the LV as well. And then you put a aortic cross clamp, and over the next 2 minutes, we can manipulate the heart. The heart will become quieter, become bradycardic. It will be empty. You can manipulate the heart and try to quickly do the repair. If you can't do it in 2 minutes, yes, you might not be able to do it in 2 minutes. Then you release the clamps. You keep digital control. And then you release the vena cava clamps and the aortic clamp, and you let the circulation to restore for brain perfusion and everything. You should never keep the inflow occlusion technique for more than 2 minutes at a given time, right? So for 2 minutes, then you rest the heart and restore circulation for another 3 to 4 or 3 to 5 minutes, and then do it again likewise. So that's an option. So don't think that you can't repair this. So try it. Otherwise, patient is anyways going to die. If you don't do it, patient is anyways going to die. So do it, think about it, and, if you have to do it, bite the bullet and do it. Okay. Yeah. So that is how you do it. Not more than 2 minutes at normothermic levels, right? So patient will be obviously normothermic. 2 minutes is this thing, but you can go do it multiple times, but at a given time, it's 2 minutes. So this is actually the picture of inflow occlusion on beating heart done for to open the right atrium to do a vegetectomy. So repair of atrial wounds, like I said, we would achieve with vascular clamps. So once the vascular clamp is in place, you might not have enough atrial tissue to suture. So you put another second Stratinskis clamp below the first one and take the first clamp out. That will give you enough suture to catch to do a secure repair. Again, it's 3O you can use 3O or 4O polypropylene sutures in a continuous fashion. You don't need pledgets in this instance, but you may use pledgets. You can close it in 2 layers, or single layer also is all right, but there's no absolute necessity for pledgets in atrial wound repairs. Like I said before, Stratinskis clamp should never be attempted on ventricles, right? It should always be hand and the Foley catheter. So this is a schematic representation where I said superficial injuries can be, safely approximated without pledgets, but deep injuries, definitely there should be pledgets used. And the coronaries, yeah, you go below the coronaries and then secure the wound. And this is again how you would do the atrial repair. I don't know whether you can see the sutures or not. Can you see the sutures? I don't know. Anyways, so it's basically a horizontal mattress suture. Ventricles, I don't think some describe they can close it with continuous sutures, but I don't think it's advisable to try to do a continuous running suture on the ventricles because it can cut through all that. It's much secure to do interrupted horizontal mattress sutures with pledgets. That gives a very secure closure line. And then you can use bioglue or tissel to achieve extra protection to that lacerated area. So basically, this new algorithm of managing penetrating cardiac trauma was kind of devised by a Colombian trauma team, which actually makes sense. So this is that reference. Rest of it is with other guidelines. I didn't have. Sorry, I couldn't put them as references. Yeah, that concludes my talk, and thank you very much for your attention. And I would like to take any questions if there are any. Yeah. It depends on the expertise. I would say a surgeon would be more comfortable in doing a pericardial window. A non-surgeon, if there's no surgeon available, a pericardiocentesis, I think non-surgical person would be more comfortable in doing a needle pericardiocentesis. So it depends on what you're comfortable with. The rationale is to decompress the pericardium, however, so you achieve reasonable stability to kind of buy time. Yeah. So there's no right or wrong answer in these situations. It's all, real-time decisions where you have to kind of take into consideration the expertise level, the skill level, the availability of resources and all that. Yeah.
What is the mode of anesthesia we use for do the pericardial window?
Yeah. The subsiphoid pericardiostomy actually can be done under local anesthesia with some sedation. It can be done without a problem because it's especially if the anesthetist is quite unhappy to anesthetize in a very unstable patient, actually it can induce a cardiac arrest, severe hypotension and cardiac arrest. So if the anesthetist is happy, you would go ahead with general anesthesia. But if the anesthetist is not happy, you can certainly do a subsiphoid pericardiostomy through local anesthesia and a bit of sedation. You can try that because the patient would be, it will be with such a pericardial effusion, patient would find it difficult to lie down as well. So you'll have to quite, prop up the patient a bit and do it. Yeah. You can do it under local if that is your, your query would have been that, can I attempt it under local? Yeah, you can do it under local. Yeah. You would need some sedation. Yeah, just to keep the patient calm. As you go down, if infiltrate the layers with local so that you anesthetize the layers as you go down. It's not only the skin. You have to anesthetize the periosteum and all that. That will make it more easier. Like in doing IC tube, you anesthetize the periosteum, like infiltrate onto the periosteum like that. Yeah. Any more? Okay. Yeah. Thank you for your attention. I think in the absence of any more further questions, I will hand over the stage to Dr. Rasnaik. Thanks.
Thank you, Aravinda, for your nice presentation. And now I am going to talk on management of airway injuries. I think it is very important because most of the airway injuries will die at the scene. It's more than 90%. And even rest of the injuries are in highly dangerous situation, even at emergency setup. If you miss the injury, they will die or they will end up with serious complications. Before you talk on airway injuries and management, it is good to know the anatomy of the airways, particularly upper airway, larynx and trachea. It's very close relationship between GI tract, esophagus, and thyroid, and particularly blood supply. Blood supply shares from the thyroid and from the esophagus, and it is segmental blood supply. It doesn't have its own blood supply. Unlike in bronchus, bronchus has its own blood supply, the bronchial arteries arising from aorta. And this basic anatomical knowledge is very important to understand the injuries as well as the management. 2/3 of airway injuries are penetrating. At the same time, it is very important, low airway injuries carries very high morbidity and mortality rate. As I mentioned, early diagnosis and prompt treatment is the major way to success. And let me introduce the causes. The main cause for the airway injury is penetrating injury. It's very common in cervical trachea and upper airway. And it carries significantly high mortality rate. And on the other hand, blunt trauma and tracheal extension or hyperextension can cause tracheal tear. And paramedian vertical fracture of the larynx and trachea. Even complex laryngotracheal separation can happen when the overextension of the neck. And the direct blows are the common cause. And even though it is not common to see this kind of laryngeal injuries, because most of them will die at the scene, this is a thing called paramedian laryngotracheal tear. It associates with laryngeal edema and airway obstruction. Another thing is padded dashboard syndrome. That is that when you don't wear the seat belts, your upper airway can be compressed in between the dash part and your cervical spine in major collisions. That is one of the major cause of serious airway injuries. But with introduction of seat belts and airbags, the incidence has been reduced. But on the other hand, bad position, incorrect position of seat belts. Can you remember that Dr. Saman showed a picture that in that picture, that lady is on the chest, there was a bruise mark at the neck, lower neck, that it is improper wearing of the seat belt, because there's you can adjust the seat belt according to your height. Otherwise, it can cause serious injuries, particularly if you wear adult size seat belts on children without having a child seat. That is a common cause. And other thing is blunt trauma can cause airway injuries when there's an explosive rupture. You breathe out on glottis. And other thing is shearing forces between fixed spine. You know that airway is fixed at the level of carina at the same time and the larynx. So the shearing forces can do damage on trachea or bronchial system. So classic injuries, anteroposterior chest compression is the main cause for carinal separation, carinal division. So I'll show you the examples. So what are the clinical signs? I told you, if you detect it at the early level, you can save the patients. So what are the clinical signs? Sometimes it is just the acute shortness of breathing following injury. You may think it may be associated blunt chest trauma or any other associated injuries. But carefully assess the patient, because you might miss a case with serious airway injuries, which just maintain their airway until they come to the emergency room. And other thing is cyanosis. Most of the time, they are cyanotic because that they're hypoxic. And they can have irritating cough. Hemoptysis can be mild hemoptysis even. It is key to think that whether there is any airway injury. Pneumothorax is a common presentation, and just carefully analyze whether there is any airway injury. And you can, if you have a suspicion like that surgical emphysema around the neck and some neck bulging, neck contusion, just carefully feel around the trachea. Then you can see that you may be able to see that tracheal deformity, right? Investigation-wise, when this kind of patient comes, the common investigation is chest X-ray. You can see a pneumothorax. It's one of the commonest presentation, but on the other hand, there can be fallen lung. You can miss fallen lung with pneumothorax. And surgical emphysema and deep mediastinal emphysema also visible. And if you have any suspicion of airway injury, just have a cervical X-ray, AP and lateral. That may help you to identify tracheal deformities and tracheal injuries. And I just want to show you on your left hand, X-rays, just little bit, it looks like pneumothorax, but it is not a pneumothorax. That if you compare with the right-hand side X-ray, it shows classic pneumothorax with collapsed lung at the hilum. But in contrast, other side, other X-ray shows that there's some kind of radio opaque mass just over the diaphragm, not attached to the hilum. So that is the classic signs of fallen lung. That is a classic sign of bronchial separation, right? It is one of our patients' X-ray. So how do you investigate that if you suspect any airway injuries? The simple thing is flexible nasal and pharyngoscopy or pharyngoscopy. Those are the common investigation to assess the upper air. It's just the upper part. But go deep inside, the flexible bronchoscopy is very, very important. It's important to assess the injury, having a confirmation of injury and assess the extent of injury. At the same time, it is very, very important to manage the airway, because you may know if you have any suspicious of a tracheal injury. Particularly, the main challenge is to get the airway without going into the false passage, without intubating into the false passage. Then what you can do is, like I have done here, you can just load your ET tube on the bronchoscope and put the bronchoscope, if you are confident enough, through the mouth. Then when you get into the air passage, a normal undamaged airway, just you can push the ET tube and achieve very good secure airway. So you can see here that I'm just inserting the bronchoscope, and over the bronchoscope, we just quickly railroad the ET tube to achieve the airway. The next thing is rigid bronchoscopy. It's a good tool. I think you all should have kind of experience that. It is important to diagnose, but mainly it helps you to achieve the airway if there's a more complex damage, because you can negotiate the damage part and go into at least single lung, and then you can ventilate through the jet ventilate through the rigid bronchoscope until you achieve surgical airway or endobronchial or endotracheal airway. So it is very important to have rigid bronchoscope available when you manage airway injuries. Other thing, CT scan, is it mandatory investigation? it is luxury to have CT scan because you can assess the detail of surrounding structures and the extent of the damage. Particularly, I told you that there can be associated injuries in surrounding structures like vascular injuries and esophageal injuries. So you can have a contrast study to assess the vascular injury at the same time contrast esophagoscopy, esophagogram. So it is important to assess those things, and the 3D, you can have a 3D reconstruction of the tracheal injury, then airway injuries, but it is not mandatory because sometime in acute injuries, it might do some harm. Like if the patient is unstable, you can do it. And on the other hand, sometime when patient has airway injuries, they use more various postural modifications, postural adaptation to maintain the airway. So if you keep the patient on supine position in the CT scanner, that is the main reason for airway obstruction. I have practically seen it because when the patient taken into the CT room, patient has arrest. Haven't you ever heard that sort of stories? Yes, it's not a very uncommon story because if you suspect airway injury, it is not essential to have a CT scan. This is a 3D reconstruction of airway. At the same time, this is a coronal section to show you the mediastinal air. So how do you now, if you have any suspicion, how do you manage? There are three things. One thing is, how do you manage the emergency settings, emergency treatment? And then some injuries can be managed conservatively without any urgent surgeries, and others need surgical treatment. As I mentioned earlier, most of the airway injuries won't come to the emergency room, and the rest of the thing, achieve the airway is the first step. There, it is very important to clear the airway and have clear upper passage. If there's a severe air leak, particularly unstable conditions, you need intubation. There also, it is very important to follow that protocols like guided intubations than blind intubation because you may open up into the false passage and you may lose the airway. And on the other hand, if the patient is breathing without any support, until you diagnose what is the type of injury, don't be hurried to give positive pressure ventilation like intubation or CPAP or face mask ventilation. Avoid any kind of positive pressure ventilation until you come to the diagnosis and you are confident about achieving the secure airway. Otherwise, you call for help, maybe ENT surgeon, thoracic surgeon, cardiac surgeon, or expert to get the advice without trying to intubate or giving positive pressure ventilation because it might damage or it may lead to open false passage. So let me elaborate how do you achieve that definitive airway? Actually, that is the main challenge in emergency room. One way is in simple fractures, simple injuries, you can have a simple endotracheal intubation. On the other hand, if there's a neck wound or open airway, they can come to the emergency room, breathing through the neck wound. Or sometimes they can have intact airway, but there's maybe big laceration. But if you think that hematoma or anything can obstruct, you can easily explore the wound, just put the tube to the wound that is called wound tracheostomy. And if you are still not confident, you can put a cannula below the larynx at any point and ventilate with the manojet or jet ventilator, or even you can give some oxygen to maintain the air, the oxygenation. And other thing is, as I mentioned, intubation under fiber optic bronchoscopy and the rigid bronchoscopy. I already explained. And with fiber optic endoscopy guided intubation or rigid bronchoscopy, you can sometimes you may not be able to achieve the airway completely, secure airway. In that case, you temporarily achieve the airway and you have to go for definitive airway management. Like you can do a thoracotomy and get a single lung ventilation. We can specifically cannulate one bronchus and keep ventilating. And while you are repairing the airway, while you do the definitive repair. And on the other hand, currently you can use ECMO for this sort of instance until you achieve the complete airway repair, or even you can use cardiopulmonary bypass. But ECMO is better because you heparinize this patient in very minimum amount than in normal cardiopulmonary bypass machines, because that they need high level of heparinization. And so it can cause various complications because associated collateral damage can cause significant amount of bleeding after airway, after this airway surgery. So that better to have ECMO if possible. This is simple wound thoracostomy, wound tracheostomy. It was done in emergency room at NHSL. So this is again that same thing. Railroading of the ET tube. And on the other hand, I just want to show this thing. And this is another guy came to the accident service. You can see that his airway was patent, but can you see there's a flap? So that is the things. If you try to intubate without helping of bronchoscope or without direct vision, you can intubate that curvature of, due to the curvature of the ET tube, it can go into that passage and loss within tissues. At the same time, when you achieve the definitive airway, you should avoid cricoid pressure. That is one of the common thing you can see when they intubate in routine theaters. They do cricoid pressure. Avoid that. And avoid blind overpassage of airway because it can worsen the laceration as well as can create false passage. And other thing, as I mentioned earlier, when there's a partial airway damage, they maintain the airway with various postural change, postural modification, and with the help of muscle tone. If you paralyze this patient without preparing for the intubation, they will lose that postural change as well as muscle tone, and then they will lose the airway. So you have to be prepared for achieving airway secure, achieving the secure airway prior to give muscle paralysis. Okay, so that is about the definitive airway, achieving a definitive airway when prior to the surgical management. So who are the patient can manage without major surgeries? Yes, there are many airway injuries you can manage without surgeries. Sometimes you won't detect it because most of the time, these kind of patients will come to us with complication because of it hasn't detected at the time of injury. One thing is mucosal tears. Simple mucosal tears, you don't need any surgical intervention. And tears less than 2 centimeter, even without significant air leaks, when tracheal tears, and sometimes less than 1/3 of the diameter, you can manage without any surgical intervention. Sometimes these patients may need even, there are some reported cases, they have ventilated, this kind of injuries, they have ventilated with selective endobronchial intubation with normal endotracheal tubes for about few days, and then they have healed without any problem. Only thing is that you should not ventilate them, keeping the tube proximal to the damage. That is the thing. So, but the main factor delaying the healing as well as giving the complication is positive airway pressure. So this kind of minor injuries can be managed easily without any surgery. And other thing, if there's no any other, that when you think of this kind of conservative management, there should not be any other co-associated injuries, because if there is esophageal injury related to this one, if there's any vascular injuries, you can't do that, because sometimes it can give you some complication like tracheoesophageal fistula ultimately. So it should be there. It is an isolated injury. And other thing is intraparenchymal bronchial injuries. You can manage without any surgical intervention, because if there's no air leak and if the lung is expanding after inserting chest drain. There also, it is mandatory to avoid positive pressure ventilation. The main principle of conservative management is you have to cover them with adequate antibiotics and need closed thoracic drain. If it is a parenchymal injury associated with intraparenchymal bronchial injuries, it is good to have negative pressure ventilation. Sorry, it is good to have a negative pressure on chest drain because it will fix the tissues around the damaged airway. So that is about the conservative management, but you have to closely observe this patient, because anytime you may need to go ahead, convert it to a surgical management if necessary. What about surgical management? If it is indicated, the earliest surgical treatment will give you the better results than late intervention. So it is mandatory to do the early repair. So surgical options are, you can do a end-to-end repair if there's a damage, or end-to-end anastomosis. Sometimes you may need autologous graft because you can't find tracheal substitute, airway substitute. It's not very easy to find. It's easy way to find some kind of autologous graft. Another thing is resection and reconstruction. And even stenting and isolated lung ventilation also there are evidence that they have used this thing also. And sleeve resection. I will explain all these things. And sometimes lobectomy or pneumonectomy when there is a serious damage. So this guy came with road traffic accident. He was in the back seat of the motorbike, and this was the injury. You can see on the CT scan, lung has fallen and lung has dropped and there's hemotherapy. Actually, that initial fallen lung X-ray was his one, his X-ray. So that is right main bronchus is completely separated and we repaired it. It's an end-to-end repair. So he was doing very well. After about next 48 hours, it's okay. And this is another case, the 3.5 years old, 3 months, 3 years and 3 months old baby girl met with an accident at her home garden. This kind of heavy chair has fallen on her chest when she was trying to climb up. Ultimately, when this patient was transferred to LRH after about 48 hours, this was a presentation that she was maintaining her airway. This was a presentation. She had a massive pneumopericardium. So you can see that pneumopericardium. So this is her CT scan. So bronchoscopically, see how severe the injury is. This is at the level of carina. You can see the esophagus behind, and right main bronchus is completely shattered and it is completely avulsed. So patient presented in about, so this is the still image. Patient presented in about 72 hours late. So there was a challenge. So how we can repair this thing? So that is the place you need that some kind of autologous graft. It may be, you can use muscle flap or myocutaneous flap. Here the problem was you can't use very thick flaps there because it might again obstruct the airway. So what I did was, I just, so this is child at that time, under the cardiopulmonary bypass, we just got a pericardium with pericardiphrenic artery pedicle. So we repaired it, primarily approximate the right main bronchial avulsed tissue, and then the gap was filled with pericardial flap. So she was okay after that. So this is her after about 72 hours, after the next day of the surgery. So she was explaining the injury. Yeah, this is next patient. Again, this guy was a motorbike rider. He has hit on a pole, the side of the road, as she has fallen asleep while riding. So he ended up with this kind of severe damage to the carina. I explained earlier, AP compression of the chest is the commonest cause for carinal injury. So it was damaged like that. You can see there's a third passage in between the bronchi. At the same time, he had his esophageal injuries associated and sternal fracture. So we managed the sternal fracture with sternal plate, and esophagus was just crushed. So what I did was I just isolated the esophagus. And this damage was very serious. At the same time, there was no adequate soft tissues around the area to harvest and do the repair. Finally, I did place a stent there, and this is just time of the stenting, and then place this stent, and this is after about 3 months. So stent came out after 3 months, and this is a guy after that. So after about 6 months, I did that esophageal repair, and so that he went very well. So according to the situation, you have to manage the type of repair. It may be primary closure, or you can do other kind of you can use other kind of homologous graft and some combination. On the other hand, if the patient has got severe injury to a single segment of the lung, maybe a part of the airway, like in this case, if the airway is damaged at the right upper lobe, bronchus, or that related area, what you can do is you can cut off the bronchus proximal and distal to the injury and end-to-end repair while removing that part of the lung. That is called sleeve resection. It also a method of repair, even though you don't need to do it very commonly. It's not frequently used method, but that you can use that. And even pneumonectomy. I haven't even done a single pneumonectomy for airway damage, but that people describe they have done. And on the other hand, you can do any kind of repair, but that it is equally important to do the post-operative care, right? When you do the airway operations, you have to keep the repaired airway relaxed by keeping the neck flexed neck. But that also have a significant complication. If you keep the neck hyperflexed position, it can cause neurological damage, right? So better not to do that. The better ask them to not to do too much extension and too much rotation movement. Because it is earlier practice to keep the neck stitched to the sternum, but there are incidents that it has caused spinal injuries, spinal damage. And then it is important to give regular mucolytics. Otherwise, the clotting of thick secretions and the blood can obstruct the airway. And maintain the moisture of the endobronchial tree with regular steam inhalation as well as saline nebulization is very important to thin out the secretion and facilitate the cough. There, you can nebulize with hypertonic saline. A regular bronchoscopy is important to achieve the patent airway as well as confirm the repair, to assess the level of repair and to confirm whether you are successful. And pulmonary rehabilitation is initiated as a gentle airway exercise, and then you have to give vigorous exercise to relieve other related complications like stiff neck and things. Always avoid positive pressure ventilation in tracheobronchial repairs and tracheobronchial injuries. On the other hand, missed injuries and delayed repair can present as infection. It's one of the common things that sometimes even that motorbike rider came with, you have seen that it's macerated, that all the tracheal injury, because it's a delayed repair, because he was referred to us not with the sternal fracture, because one thing is that is infection. So that is one of the common cause. Other thing is that when it is delayed, there can be retraction in that child. So it is very difficult to repair and the high chance of failure rate. And there can be associated tissue necrosis. So that is why you should do the early repair and adhesion to the adjoining organs. And if it is late or missed, there can be scar formation or stricture or fistula formation. And sometimes loss of lung segments due to pulmonary atelectasis or abscess formation. So this is one of the common complications. So this missed airway injury. So you can see that how this stricture has formed in the trachea. There's a significant history of tracheal trauma. It's a blunt trauma to the trachea. So it has ended up with thick scar. Now the thing is that I have managed it with laser, but at some time this kind of scars should be excised with end-to-end anastomosis. The main problem is most of the time it is very difficult to dissect around the recurrent laryngeal nerves and all the associated structures. Sometimes they can ended up with hoarseness of voice. So this kind of complication can be occur if you miss the injuries at early stage. So this is the things basically I just want to highlight you about the airway injuries. But if you have any question, it's welcome. And I just went through the most of your questions, but I didn't find any significant question related to the airway injuries other than someone highlighted. So if you have any queries, you can ask. Yeah.
For example, if there is no deteriorating symptoms and signs, and if there is good lung expansion after
Yeah.
insertion of chest drain, so but how can you differentiate between those type of injuries and those injuries that might need repair to prevent delayed complication?
Yeah, it's a good question. Because if there is no complete separation, it's about maximum one third of the diameter involved. At the same time, if the patient is not ventilating, and when the patient should be on a chest drain, and there should not be significant pneumothorax or air leak after applying a suction on the chest drain, because it will adhere the lung to the chest wall and there won't be any dead space. And there is no dead space around the peritracheal hemorrhage or anything can be visible. And when you manage conservatively this kind of patient, it is necessary to do the post-operative x-rays and CT scan to find out whether you are successful. You can do CT scan in about 1 week time, because at that time, all the edema and tissue deformities associated with acute injury has been reduced and subside, then you can assess whether you are in a correct pathway. Otherwise, if you suspect a major injury, it is better to open and do the repair than going for conservative management. It's depending on, but at the same time, to do the surgical repair, you need to have adequate facilities. And another thing I just want to tell you that repair, when you consider repair, what is the kind of suture material you have to select? Generally, you use absorbable suture material. It's better to have a monofilament absorbable suture material with delayed half-life, like dyed monacryl or PDS is ideal. Otherwise, it can cause foreign body reaction and cause further scar formations. And use the as much as smallest suture material you can. Is it clear to you? Is it okay? Am I answered your question?
Yes. Thank you.
Okay. Anything else? Right. Thank you very much. So if you have anything to ask, just feel free to ask. And thank you very much. And it is time to have a cup of tea, and it is time for the tea break. Right after that, Dr. Handakala will discuss about the.
Yeah, I believe. So how many of you are from the new batch who passed the screening exam? අලුත් අය කවුරුත් ඉන්නවද? Nobody. රෙකෝඩ් එකක් තියෙනවද? මගේ no no in the computer. Patient people ask questions. No. Calling කරනවා නේද? Then, sir, up and down here. Right, good morning again. And then this is the topic I'm going to discuss, the management of intercostal tubes, the tips, because this is the most basic surgical procedure that we do from a thoracic point of view, but it's the most complicated one if you don't do it properly and if you don't manage it properly, unfortunately. So my talk will be on this agenda: history, bit of indications, then types, procedure, post-insertion, and when to discontinue, then complications, then options for long-standing tubes, and when to refer to a specialized center, then follow-up, and points to optimize patient safety. If you talk on history, the insertion of tubes to the chest goes back even to the era of Hippocrates, who had drained empyemas using a hollow of tin tube. And then what he has done initially is he diagnoses first, and then if he's convinced that it's an empyema, he uses a scalpel and he inserts it only up to about the size of a nail, and then a tenth of raw linen he has inserted into the chest, and first drain the empyema and then put the tube in and wait for some time, and then after about a week, when he's convinced that the thickness of the fluid is less, then he has put wine through that tube. Wine clean කරලා. Then he has gradually taken the tube out, and maybe a centimeter or two, he has gradually that's what he has done. Then in the latter part, one S-bend back, he has written actually regarding a tube thoracostomy. He has used a bark of linden tree. I don't know, but it may be in that country. Then comes the water seal drain system first come into play during 1873. So what are the indications? Emergency and elective sessions, then pleural collections of either fluid, air, or debris. Then post-operatively during cardiac, thoracic, maybe esophageal surgery, we do tubes. Prophylactical esophageectomy, and maybe a pre-transport of a critical ill patient. Unlike in our setting, the developed countries, they have, the ambulance or the outreach team, the trauma teams, and they put, if the patient is critically injured, they put the tube then and there in the field. Right? So need to be cautious of previous pleuro disease, and in case of lung transplanted patients, and if the patient had history of extensive Blebs or bullous disease or coagulopathy, so we need to be careful without rushing, and need to think twice. And post-pneumonectomy patients as well, because they collect tubes. Some may Somebody may diagnose it as an empyema or a big pleural effusion and rush for a tube. We have lost patients by people doing that. So indications for pleural aspiration, first is pneumothorax, spontaneous pneumothorax, primary one, and spontaneous secondary pneumothorax. Then malignant pleural effusion, small volume aspirations for diagnosis, and large volumes to relieve symptoms or dyspnea. Or maybe before we do a CT scan, we get a better CT picture if we take some fluid out. If the effusion is very large, the lung will be scotched, and the CT picture that you get will be, in low quality. So better to aspirate some amount of fluid and then do the CT scan. And pleural effusions associated with sepsis, like suspected empyema. And it could be diagnostic for decision making, whether to put a drain or not, and refer to specific guidelines for further details if necessary. For chest drain, in any ventilated patient for pneumothorax, then tension pneumothorax after initial needle relief, or persistent or recurrent pneumothorax after simple aspiration, or large secondary spontaneous pneumothorax in patients aged more than 50. Then comes malignant pleural effusions, maybe plus or minus pleural disease if the lung expands well at the end. Then empyema and complicated parapneumonic effusions. Then traumatic hemopneumothorax and post-surgical, maybe thoracotomy, esophageectomy, or cardiac surgery. When in doubt, in pneumothorax, you may observe or intervene, and it will depend on the severity of symptoms, its size, and presence of underlying lung disease, and patient social status, whether, say, if it's a child, whether he's sitting for an exam in near future, or whether he's going to fly to other country, or whether if he's a, say, military person, whether he's going to be away from normal community, like no medical facilities are available. Those are the things that we need to consider, whether we should observe or whether we should put a tube or whether it should go for a definitive procedure. And in case of fluid, whether it's unilocular or multilocular. If multilocular, maybe the patient is having a big, large pocket where you can put a tube in under ultrasonic guidance or ultrasound marking. Just because the CT comes as multilocular pleural effusion, I mean, you should not refuse the IC tube. If it's a very large one with small, tiny ones, then you may put a tube well into the large one. Then post-op, simple procedure versus volume compromisation, and chances of life-threatening bleeding also there. Then pre-transport, as I told you, a critically ill patient or in between hospitals. If you think that patient might, deteriorate, you better to put a tube in rather than not doing it. What are the tubes types? The conventional ones are there with or without trocars. Then there are straight tubes and curved tubes. And the sizes may vary from 8 French to 40 French. And I mean, they're suitable for newborn to adult. And there are newer techniques like Seldinger technique kits are available. Then there are long-term pleural catheters. These are not the ones that we use usually. And there are alternatives like maybe pigtail catheters under ultrasonic guidance. Then in rare occasions, especially in posterior, we might put a Foley catheter. There's a small new gadget called pleural vent. I'll show you a picture later. Insertion site, conventionally, they say safe triangle. Now, the safe triangle definition change, it's no more the posterior axillary line. It's the mid axillary line, anterior axillary line, and the fourth rib level. And other alternative positions you can do with ultrasonic guidance. So if you are competent in ultrasound, you may choose a site well suitable for the inner collection using the ultrasound. You don't have to be going in the safe triangle essentially. And especially in posterior locations, I have mentioned here, you may not use this position. You may ask the patient to, sit up, like, rest this thing on some table or something, and you may go from behind in the seated position. The procedure need to be sterile all the time, and anesthesia depend on the age as well as the anxious nature of the patient. May do under local anesthesia most of the time, but may require sedation, and in case of a child, may even general anesthesia. Size of the cut on the skin, you need to be mindful because the tube has a perimeter. It should not be just diameter of the tube. So it has a perimeter, so it should be slightly larger, which the tube should not be snugly, going inside the skin. But it should not be too large also, right? But you may make a too large incision in case of an obese patient, right? Because otherwise you may not be able to go in. So might as well suture the skin cut tightly, but you may not be able to go in a very obese patient if you make a tiny cut. Then blunt dissection using appropriate instruments. If it's a tiny patient, you may use a small blunt mosquito, or usually what you use is a Robert's forceps to go for blunt dissection. So the direction, you make an incision and you direct upwards towards the upper intercostal space because there is this tract of tissue will prevent surgical emphysema, and even after removing the tube, it will close nicely this flap. So you go in sort of upward direction, and you should go above the upper surface of the rib that you want to put the tube in, and then direction of the tube depend on the air and fluid. Initially they told if it is fluid, it should be directed down, and then if it's air, it should be directed up. But if the pleural cavity is unilocular, the direction doesn't matter actually. If the lung expands, whatever inside will drain, provided that the patient is mobilizing well or giving good physiotherapy. And anchoring also, you may use stitches and tapes, but I know some general surgeons, they use just tapes without suturing. But as cardiothoracic surgeons, both cardiac and thoracic, we use stitches as a first thing because we have seen patients after removing getting complicated by recurrent effusions or recurrent pneumothorax. And procedure will depend on clinical signs and symptoms. And then after, how to confirm the position. After putting, you need to do a chest X-ray always. And then clinically, you can see there is a mist of, mist form when the tube is actually inside the pleural cavity. You can see visually a mist in the tubing. And once it's connected to the bottle, you may see bubbling and drainage of fluid and swinging of the water column. And radiologically, X-ray or ultrasound, right? And you should make sure that the last hole of the tube is inside the pleural cavity. That is a must. So that's why you need this X-ray to see whether the tube has not gone in any awkward places, but all there is a radiopaque line on that. That last hole should be within the pleural cavity. Is called sentinel hole, right? Most peripheral hole. And before the procedure, actually, you need to make sure that all the required equipment like tubes, bottles, sterile water or saline that's used to fill these all are in handy. Because when you, after, passing your part 2 exam, when you go for foreign training, these are in different cupboards. You need to know where to collect them, which cupboard this is in. Local anesthesia is under lock and key, under sister, as safety measures. So different cupboards, you need to know where your stuff are. Nobody's, no attendance, If you are given a procedure to do, you have to find stuff and do yourself. So you need to do, in the first week of your life in your new place in foreign training, you got to find where these are and then collect first. මොකද කරලා ආය කවුරුත් නැහැ අතරමඟදී ගේන්න. මේ මිසි අරක ගේන්න කියලා කෑ ගහන්න කවුරුත් නැහැ. If it's not available handy, it's your fault eventually, right? So we need to find your equipment, sutures, ඔක්කොම ඒවා ගෙනලා ගන්න. And especially this type of bottles, you need to connect the tubing into the correct port. Samaru vent එකකට ගහනවා tube එක, so vent එකට tube එක ගහන්න බෑ. The tube coming from the patient should go into the patient port. That vent is to, when the fluid comes, this air should dispel out so that there is space for the new stuff to fill in. So that vent should be open to air, or it should be connected to a wall suction or suction machine. Right? It need to be because that happens only in this type of bottle. But this time, this bottle, this bit comes and it has to be screwed to the bottle only in one place. It happens only this type of bottle. And the air vent is open is important. And some countries, they have, bags. Even during COVID period, we had these bags. Now it is very rare to find, but we might use a URI bag instead if the patient is going home, because there's a small valve effect here, allowing unidirectional flow only this area, and it can be emptied. So advanced bottle systems are there, so you don't have to worry at your stage. Wet suction, dry suction, then air leak monitoring devices. Post-insertion, chest physiotherapy and drainage chart, how frequently, if it's a post-operative, you may chart even hourly or half an hourly. But if it's just an effusion, you might drain twice a day or once a day, right? Then mobilization, whenever safe. If the ventilator patient very moribund, on 9 drops, you can't mobilize. But if it's a normal person, we need to mobilize. So this is very important, because in general hospital, there was a situation we receive patients after ICU tubes, for weeks or sometime even a month. And then when they put a tube in, patient is asked not to move. And then they put a catheter also, urinary catheter. And the next day they start, low molecular heparin also, because patient is not moving. You see how otherwise normal patient, just for an effusion, they make a real patient, and all sorts of other problems come into play if you don't mobilize. Maybe ICU patients or fracture patients, you can't mobilize, but whenever possible, whenever safe, we need to mobilize. Then decision on applying on low pressure suction. If the lung is not expanding well, if the patient can't be given physiotherapy, then you have to decision. It has to be a consultant decision whether to apply suction or not. But if you apply too much of suction, that will be detrimental also. So it might lead to barotrauma, lung rupture and mediastinal shifting. And if it's a very old, frail, 85-year-old person, might die of that even, right? And the tube dressing once in 2 to 3 days. And if the dressing is wet, better to change it. And prophylactic antibiotics, and they have proven that less infection by 12.5% if you use prophylactic antibiotics. Post-insertion again, check the connection and function, especially after posture change. If the patient is coming after X-ray, we better to change. And leaking at the tube sites. Then whether there is any surgical, those are daily ward round, observations. And frequency of change in the bottle. Right. If it's a too frequent filling, or say massive effusion or malignant effusion, you may have to change it very quickly. Or pyothorax or empyema, there, if you leave it alone for a long time, because that vent is open to air, it might be a culture medium and it can go other way, like an ascending infection. Better to change if it's a horrible collection. And simple effusion and pneumothorax, you may keep even up to about 4 to 5 days without changing the bottle. And when to remove? Ideally, when the lung expands with no residual air or fluid, or less daily drainage if it's after operation. And we have radiological and clinical finding correlation. Let's say after lobectomy, if the lung is not fully expanded, if there's a persistent gap, say 1 or 2 centimeters on the top of the lung after lobectomy, we might remove the tube, accepting that gap. It's not a pneumothorax, actually a gap between the lung and there may be some air, but it's an accepted gap. Right? So assess the general status of the patient, right? And then again, that procedure is a sterile procedure with or without local anesthesia, depending on the patient's anxious level. And if it's a child, better to apply some embla, local anesthetic cream around the tube and take it out. Right? And what phase of respiration is also 2 different schools of thought. And some may do in deep inspiration and some may do in full expiration. You can practice both, but you need to ask the patient not to change while you are pulling the tube in, not to shout. And whatever method you do, if the patient is not cooperative, air might suck in. Right? And full inspiration also, the problem is patient may not have taken full breath. Still there is, negative pressure. We think full inspiration when the chest cavity is full, but still there could be a negative pressure, especially muscular patients who they they have some more space and creating more negative pressure inside, right? And deep expiration also, the next cycle in the respiration is inspiration, right? Deep expiration also, it could be tricky if you don't, time it well. So you'd adopt a method suitable to you. There is no hard and fast rule whether it should be deep inspiration or full expiration. And if the patient had been on suction on the ICU bottle, better to go back to a water seal, that is off suction for a day or two, and check the x-rays and then remove. Because while on suction, if you remove the tube, that may not be the patient's normal status. Right? What are the complications? Can be immediate or intermediate or late. Then poor placement could go into subcutaneous or intramuscular hematomas, patient discomfort, non-functioning tubes, bleeding, surgical emphysema, hypoxia, then rapid re-expansion causing mediastinal shift, then central chest pain, sweating and hypertension might cause even a vagal attack, because there is a phenomenon called re-expansion pulmonary edema, especially in case of very large effusions, especially in elderly. We should not remove more than 1 liter. You remove 1 liter and then you need to clamp the tube and ask the ward staff strictly to release 250 to 300 ml per hour and reclamp. And that also you have to advise. The nurse might be busy in that cubicle and may come and, just unclamp and give the injection to the other patient. By the time she comes, another 1 liter might fill in to the bottle. So she has to be there and watch that the next 250 or 300 ml drain and clamp. So that advice we need to view. And when the daily, hourly drain is less than 250, then you can leave it unclamped. And death might have happened with major bleeding or even cardiac puncture. The cardiac puncture has happened about 2 decades ago in one of the down south hospitals. They put in a trocar tube to straight to the heart. So things have happened. And intermediate complications are pain, malfunction of the tube, and then arrhythmia, so ischemic cardia, especially if the tube is touching the pericardium. Then signs of infection and kinking and blockade of the tube, and then accidental fall or dislodgement, then bleeding from IC tube side, especially those who are on aspirin, clopidogrel, anticoagulants, and then difficult to remove. You may, if the hole is too small, it may be stuck somewhere, so it may be difficult to remove also. So might need local anesthesia and sometimes even general anesthesia if you can't remove it in the ward setting. And pneumothorax or space around the lung just after removal. A small gap you may observe if the patient is symptomatic, and if it's a significant one, then you may need ultrasound guided aspiration or even place in a new tube. What are the late complications? Again, the tube site infection, pleural space infection, scar, fistula, pain, and in case of malignant diffusion, tumor deposits in the tube site. So there were situations where inadvertent tube placement occurred. It may be simply in the chest wall without going to pleural cavity. And honestly, the first tube may be, the tube may be inside the pleural cavity, especially in elderly. Their skin is very stretchable. Elderly people, because of the plasticity, their skin can even pull about 5 centimeters out. So with that pulling, poor patient lifting to the bed from trolley to the bed. So this movement is quite enough that inner tube coming in and lying on the chest tube. Right? That especially in elderly, we have to think that the elasticity of the scan. That's why in the first instance, when you put the tube in, the tube has to be well inside the pleural cavity. And then there were tubes in subdiaphragmatic space, puncture in the liver, spleen, stomach, bowel, kidney, injury, all have been reported. And perforation of the heart, great vessels, and intrapulmonary or even hilar injuries, panic nerve injury, tracheal injury, and tubes going into the bulla or abscess cavity inadvertently. And pneumonectomy space, I told you, and there was a patient, one of staff patient's father, that he admitted to Margam Hospital for 3rd chemotherapy, and the medical officer quite clearly diagnosed an empyema on a pneumonectomy and put a tube in and got an ascending infection. He died. So pneumonectomy, we expect fluid to accumulate. So you go through the nose without rushing, is a pneumonectomy. empire කියලා පටස් කරලා බට දාන්න යන්න එපා. Right? What are the management options for long standing tubes? Now, we need repeat imaging and consider adjustments or maybe a second tube insertion. And we can do pleurodissease if the lung is well expanded, and there are different techniques. And decide on operative management, may liaise with thoracic or cardiothoracic team. And you might decide to, if the patient is not wanting or if he's not fit for operative management, may send home with the tube in. And you may connect the tube to Helminch valve. It's a unidirectional valve which can be connected to the tube. So it won't allow air to go back, but it will allow the air to go out only. And there are certain bags I showed you with the valves. And pleural vent is another option for the chronic pneumothoraces. This is a small gadget, costs about 40,000 rupees. And it is inserted under local anesthesia. There's a same Seldinger technique that we use. Make a podi kurak wagak කරනවා with a flexible tip, and you insert under local anesthesia. And there's a valve effect. Here there's a like a fishtail, there's a unidirectional valve, and air is expelled through. There are holes around this plastic piece. So you stick, and even you can send the patient home with this. And if there is fluid connection, you can aspirate through this. Sometimes if there is hydropneumothorax, fluid might accumulate. You can aspirate, fix in a syringe here. And if it's blocked, you can flush here. There's a small stopper here. If you remove it anti-clockwise, you can connect a syringe and again aspirate it. This is a very good one. Especially we have used this one for chronic pneumothoraces. One girl we used for bilateral pneumothorax with a miliary TB. And eventually patient sent home with expanded lung. And in between, she went home also with this gadget. Apparently, in developed countries, they use this as sort of alternative for IC tubes also, but in our country, we've never tried that. If you decide to send home with the tube, consider education level and social background of the patient, whether he can manage it, and whether there is any hospital around, whether there is somebody home to bring the patient to a hospital or medical attention if something happens. And Helminch, I told you, and probably silicone catheters you can keep up to about 3 to 4 months even, compared to normal tubes. And commercially available user-friendly smaller bags I told you, and alternative bags with Helminch valve effect. And sometimes even if it's a chronic sort of pleurocutaneous fistula, we have fixed even normal colostomy bags. Surgical options to minimize tube wear in time. And the exact procedure would depend on original disease and prevailing status of the pleural cavity. For example, original simple pneumothorax may present with stage 3 empyema or a bronchopleural fistula and chronically collapsed lung by the time the patient comes to the thoracic unit. Right? So pleurectomy, decortication of pleurodissease, or either open thoracotomy or VATS may be necessary. Sometimes even lung dissections, bulectomy, blebectomy may be required, depending on the primary pathology. So to minimize the tube wear in time. So when to refer? Before a tube, if you have a suspicious imaging. Then predict post-insertion need for thoracic input. Right? So you can put a tube in, but better to call and then send. Then history of previous thoracic or cardiac surgery. Those situations, even before the tube, you have to consider referral. When to refer? Early, in unexpected bleeding or significant air leak or bubbling. And if your chest X-ray shows a tube traversing through the lung or something. Patient going into sepsis, worsening of surgical emphysema, or worsening of hypoxia. Then image showing loculation of fluid despite the tube. Poorly expanding lung despite low pressure suction. Then patient planning to fly in near future or to be stationed in a place where no easy access to medical facility. Told you early. When to refer in late stage, long standing tubes again, unresolved pleural space or collapsed lung, or prolonged air leak. And if you're in doubt about underlying disease process. Follow-up. When you need to do serial chest X-rays, look for tube site tissues like scars, tumor deposits, infection, pain, air leak, fistulation, or there could be missed stitches. and need to arrange chest physiotherapy, breathing exercises, and incentive spirometer or some balloon thing, patient should be emphasized that you need to do even at home. And then evidence of persistent original disease, or may consider thoracoplasty with or without plastic surgical input. Or either we may make a window or do some other procedure depending on the original pathology. And general message is taken for granted as a simple procedure. With our time, when we were house officers, the patient, no PCUs, no A&Es, patient straight away came to surgical ward and we put tube. That's how we started putting tubes. Right? But it may be delicate to the most junior one, no, SHO or registrar or even HO. When the attention needed, even a consultant should put a tube in tricky cases, right? Because it can lead to significant morbidity and even mortality if you don't do it properly in first instance. And mobilization is very important whenever possible. I told you, and we need to consider about the cost of tubes, bottles, antibiotics, hospital stay, and we don't cost it as in day by day, and cost for operations and cost for complications, like say if it becomes an empyema, need an operation, all that cost, right? Taxpayers' money. So if you don't do it in the first instance properly, either somebody will be spending, that's all our money, taxpayers' money. And then lost working hours for patient and psychological impact and intangible cost to the relatives. Each day somebody has to come and see the patient, all that matters. So do it correctly first time, please. So to optimize the patient safety, need to check the indication, check safety checks like identity check, right side, they have put tubes to the opposite sides. This WHO checklist and all, although it's not done under general anesthesia, it applies to this also. So need to check the patient on the side and where and when to perform. Theatre ke karna hoda, what procedure room mein ke karna hoda, whether it's done in the ICU bed. So that you have to decide depending on the how urgent the tube is and how bad the patient is. And adhering to universal precautions for invasive procedures anyway. And maybe patient is HIV positive, maybe a prison patient, we don't know, drug addict. So take, if you double glove, if you are in, because you no time to do HIV or hepatitis B, double glove and do it carefully, right? And if the patient give a good sedative and do it without hurting yourself or without puncturing your assisting nurse. Then check pre and post-operative insertion chest x-rays and consider reposition if needed or second tube maybe. And proper post-operative care and evaluation of the progress and medically as well as the nursing aspect. And due care during removal also is a sterile procedure. And pay attention during the removal, as I said, the breathing cycle. Then adequate training like didactic lectures or simulated training or assisted procedure first, and then so that it should be house officer should be trained, a progressive manner, how to put a tube, first watch, then assist, and then ask him to do. So that's how you can train a house officer. And if you teach, and you will master the technique as well. And now the ultrasound is coming. With last week also they had this ultrasound for trauma. Not only trauma, now it's coming into play for all aspects of medicine. I think it is high time the radiologists should strongly think of releasing ultrasound to general public, like general medical profession. So because I can remember that time when we organized some ultrasound course, so they were very reluctant to teach even basics of ultrasound, so it's their property. So it's high time to release the ultrasound. It's just a basic tool. In UK and other developed countries, you can't put even a neck tube or neckline without ultrasound. If you do and something happens, you have done a what do you call, it's a medical negligence, right? When you have the stuff, you have to use it, right? So it's that important. It's in ICU, intensive, everybody use ultrasound. Like for trauma, we use for PAS scan. So in a doubtful situation, if you have knowledge of how to do ultrasound, you may take ultrasound and do, then you don't have to go in the safe triangle, but you can insert the tube in the proper place actually. And then troubleshooting is a matter of knowledge, experience, and vigilance. If you're not sure if you are junior, ask always a senior or your consultant. or refer to a thoracic center or call one of us and we will help, and stick to guidelines if available whenever. There are different guidelines for different hospitals, ESTS, BTS, British Thoracic Society, American STS guidelines. Different hospitals use different ones. So they keep on changing as well, right? So stick to, if there is any guideline for your hospital or your trust, stick to that. I acknowledge staff of Valisara hospitals and college of surgeons for us to give this opportunity to deliver this lecture and for you for participation. Any questions, please, on this? I got another one. And that stitching, what we use is to anchor is number one, nylon. You can use a thick silk as well, because last time we didn't have sutures available. These days there's issue of unavailability of sutures. So then without putting, we lost some patients also while waiting for, sutures in Valisara hospital itself. So if it's a hurry, you better do at least needle aspiration or put in a, cannula into the second space or safe triangle to release it. You know that, no? Now no more in the new ATLS guidelines is no more in the mid axillary in the needle puncture. It should be in the safe triangle, right? So use the 3-tape technique. You can strip say elastoplast into 3 pieces, and the middle one will go around the tube and the 2 side ones onto the patient's chest, right? The 3-tape technique. And even there's the tegaderm and all stuff, they have very sophisticated, dressings for tubes itself. But you have to anchor it somehow. So better to put a stitch, I believe. Otherwise, you have high chance of pulling, our patient care. We are not there all the time to, monitor how they are handled. So minor staff member may, just pull the patient from the bed to the wheelchair or trolley. So might well pull the tube and it might pull off, endangering life and putting the patient into morbidity. Yeah, that one. Any questions on tube, please? Next one will be a very short one, actually, just to summarize. So anybody sitting exam, next part 2 exam, MD surgery? Hands up those who are willing, going for the exam. Fine, okay. That's mainly based on you. And so the next topic would be cardiothoracic surgery in MD surgery exam preparation, and I'll give few tips with regard to future scope of the field. Because I think I'm entitled to do this because now, in addition to my normal title, so I'm the vice president of our association, and I'm a member of the specialty board of the PGIM, as well as I'm examiner in the MD surgery exam. So I think I have ability to give you some insight of the topic. So the definitions, now our field is divided into 3, called adult cardiac surgery, then congenital cardiac surgery, and it goes with pediatrics, and then thoracic surgery. And in other countries, the vascular surgery and transplant surgery also will be coined, depending on the availability of the facilities. So a cardiothoracic surgeon or a thoracic surgeon, yeah. Okay. Tell them that we'll answer at the end. So sorry about those who are in Zoom link. We got a question from Peradinian, but we will answer at the end of this one, right? Right. And depending on the availability, some thoracic centers, they do vascular surgery also. Now, with regard to Sri Lankan setting, the vascular surgery, surgeons will be involved in descending aorta, distal to the subclavian artery, left subclavian artery. It belongs to the vascular surgeons. What is proximal to the left subclavian artery will go to the cardiothoracic surgeons. In our country, our thoracic training does not involve vascular surgery, but we may do some vascular work with regard to pulmonary arteries, sleeve resections, but we are not supposed to do vascular surgery. So depend on the country and their program. So you may do vascular, you may not do. And transplant surgery also, you may be enroll later on. And if your center has, you may learn transplant surgery as well, maybe heart or heart lung or both. That's how it goes, right? And with regard to cardiothoracic centers in Sri Lanka at the moment, NHS, I think there are 6 units now. Javardhanapura 2 surgeons, LR is 3, in Karapitiya 3, Kandy 3, and those are cardiothoracic units. And also Miss Jaffna, I think. Jaffna also there are 2 surgeons, right? Then with regard to thoracic, Valisara we have 4 surgeons, and Goal and Kandy are vacant still. In future, we may have posts in NHSL stroke LRH, then Jaffna, Batiklo, Anuradhapura, a lot of provincial hospitals. Then in private hospitals, in Colombo, there are 5 units in different private hospitals. And then Kandy, Jaffna, Goal, they have 1 each private hospitals. And there are upcoming units in Kothalawala Defense Academy, University Hospital. And then Kurunagala, even the surgeons are, posted there, but no unit still, right? So training duration, as a general surgical registrar, you may get 1 month of cardiothoracic and 1 month of thoracic surgery. And during that 1 month, we expect you to learn basic thoracic principles, how you investigate diseases. So mediastinal කිව්වොත් මොනවද කරන්නේ, that even there are, nearly retired in chest physicians sometimes send a patient for mediastinoscopy where the lymph node is not situated in the proper place. So that needs either mediastinostomy. So they are also not clear. So because these concepts need to be learned, because these will come into your question paper. So that's basic, investigation, what we do, like VATS investigation or bronchoscopy, stenting, all those, you need to consciously learn. We don't expect you to master the technique, but watch carefully what you see during that 1 month. And post-MD training, cardiothoracic surgery as well as thoracics, so we have 2 years of local training and 2 years of foreign training. Right? And there is little bit of overlap. In thoracics, you will be sent 2 months to do work in the cardiac center, and the cardiothoracic SRs will also come to the thoracic to learn some thoracics. That's only that. Between our time when we were trained, we were in 1 year in the cardiothoracic units doing cardiac stuff. That is because there was no trainer available to go. But now it's more systemized. So you'll be staying 2 months in the other field. And in addition to that, you may stay in the ICU, probably cath lab to see what's happened, if it's a cardiac training. So with regard to MD exam, so this cardiothoracic surgery may appear as MCQ or EMQs. According to blueprint, all questions divided among the subspecialties by the chief coordinator of the exam. So the 4 examiners usually are from cardiothoracic and thoracics, and 1 each will be given to bring 2 MCQs and single EMQ. So out of that means altogether about 10 or 12 questions. So out of 4 EMQs, we will be selecting 1 EMQ that matches for that paper. And MCQs are actually single SBS, no? You come single best answer. About 3 or 4, not more than that, from cardiothoracic surgery. In the paper, 1 EMQ and 2 to 3 MCQ, as I told you. And how about the essay? Occasional short note may come, like say empyema or something, just trauma or something might come, but it's not a frequent, regular event. Last exam, muku tawada samira. Cardiothoracic in essay, nothing, no? Yeah, in previous year, no. Yeah, that comes to the vivas, no? Yeah. Viva, radiology viva, principles and operative surgery again. They will ask you common topics. Say if it's radiology, X-ray with some abnormality, and then you will be taken to pneumothorax or empyema, and your discussion goes on. And they might ask IC tubes and thoracotomy during operative surgery. And sometimes there are frequent cardiothoracic surgeons who come as examiners. So they will be seated in one of these stations, definitely. So he will be fancy asking a question. But nowadays, unlike those days, they can't ask questions from their own mind. Old stereotype, you can't ask straight questions. If the previous candidate who asked the same set of questions, they need to ask from the next candidate also. So there is no in between the candidate variation and but he may fancy put in a question into one of those if that foreign examiner is a cardiothoracic surgeon. So and pneumothorax, like simple stuff they might ask in the but you should be able to tackle it accordingly. Then the most important thing, what to select after passing MD surgery exam. Any question from exam point of view? Paper? And I should tell something because closer to the exam, some registrars, they send me or ask question. We had a Zoom link also. Some questions that appear in the paper, like we all also did that in those era. And you jot down after the exam and you make a paper out of your memory. And most questions, they miss some parts, some crucial bits miss. Sometimes if you ask a question, even I can't answer, even if it's my question, because some parts are missing. So because we may not memorize, but a question, then I go to, because at the end, if I talk to you about the exam, the blueprint in examiners la, we put it this way and it will be scrutinized again. You can't have ambiguous questions. Most difficult questions you can't. It should be general questions applicable to general surgical registrar, right? So after so it will be gone through by 20 odd consultants who are experienced examiners. So that's how a question come to the paper. If we have not, boiled down to one single answer, SBA, if the answer is not, if you can't sort of, tailor to one answer, that's a bad question. So that question may not come to the paper because that if some other examiner can't, imagine if Dr. Niaz is an examiner, if he can't answer that question properly, that question may not come to the paper. So that's how it's very transparent, right? So we don't put tricky questions, ambiguous questions. So the paper compiled by you at the end of the exam, after coming out of the hall, may miss certain things which are crucial to answer that question. Right? So, right? But you are well guided in that question or the stem of the question to lead the proper answer. All right. Next, this topic, what to select after passing MD surgery exam. And I know there are several factors. Firstly, the personal liking. So during your career or maybe not most likely internship, but during your registrar career, you have some liking. Maybe you are following your role model, a good consultant that you think is the best idol in your life. And so that may take you to select one thing, right? You may not think of your ability to dedicate, to that field, right? And then availability of a training. Even if you like, your post may not be available in the vacancy list. Then you have to have 1, 2, 3, your choices. You have to, you release your first choice, but you go to your second choice, right? Then availability of the trains, I told you, and duration of train. You might think of, cardiothoracic, thoracic, orthopedic, neurosurgery, all include 4 years of post-MD training. So you may not want to say, maybe you have done your exam later and you want to finish off this bloody thing and then be a consultant soon, then you might select general surgery. So there are things, right? Then how easy to get a foreign placement or job, or is it a job, or is it an attachment, right? So those things you might think of. And then post-board certification job placement. So where the hell you are going to be placed if you come back after foreign training, right? Is it in Mahiyangani, Ampara, Akkarepattu, where, or Mondragala? So those factors. And then you might well consider your family, how old your children are, whether you can take your family there. If you are really a family man, you want them to be together. Do you like break your child's education in one of the Columbus schools to go to, say, Kilnocho somewhere, right? So those things come into play. These are the factors, genuine factors that you think when you go to select a field. And then obviously you might think of income and earning ability also, right? Consultant you need money to spend also, to feed your family, to buy a good car. So that also matters. And obviously nowadays you would think of stability of the country, economy, and otherwise, whether is it I will go to somewhere, those things, I know those are things, crossing in most people's mind these days, no? So these are the factors actually, right? So anyway, that if you have a personal liking and dedication, and if a slot is available, I think the first three are the most key factors. All others you can adjust. Country situation, of course, we can't to change, but to decide on first three, personal liking, dedication, if you are dedicated, say if you do cardiac surgery or neurosurgery or transplant, you have to dedicate out of the hours. Like you can't have good sleep, all that you have to dedicate. Immaterial, but if you go in the first three, so that's should, because that's a lifetime, it's more than marrying your wife actually, right? If you are bound to, so I'll show you a picture. Imagine this bloody dog has, inadvertently gone in a wrong place. So once you are trapped, you need somebody's else's help. So where you have no escape, right? Poor guy. And but there was a situation where, on medical grounds, our surgeons, there was a neurosurgeon, there was some cardiothoracic surgeon who quit the field because on medical reasons, right? That's a different story. But if you are doing a very general job, you may be trapped to unsuitable job. So that you have to decide before selecting, right? So what are the qualities to be a cardiothoracic or thoracic surgeon? Dr. Nia, sorry about, because we last exam, we got only one thoracic trainee came to our field. We need to do some sort of marketing, to attract them, right? I know. Then one should be ambitious and passionate about the patient care. You can't be just නිකන් ඇවිල්ලා මොකක් හරි කරලා ගෙදර යන જાතිය surgeon කෙනෙක් is not suitable for cardiothoracic or even thoracic, right? And you should improve you should have potential to improve your technical proficiency, right? I mean, initially, actually, when you come to cardiac and thoracic, we want to undo your normal general surgical techniques and relearn the techniques from, from the scratch, from the grassroots level, because that has to be done. Our knot techniques, suturing techniques, how you handle the lung may be different from when you're suturing, say, lacerated skin or something, right? So we have to undo and relearn. Then extensive medical knowledge and basic science. Then current advancements in the medical research and new techniques. So you need to have good medical knowledge also, especially basic techniques, basic anatomy, then pathology, and physiology. Very important. You need to be a master of those to select cardiothoracic and thoracic, because that's important in your day-to-day practice and decision making. And as I told you earlier, dedication and availability, right? Then analytical thinking and problem solving ability. So that comes with your experience. And then pay attention to minute details. You even from the skin to until you put the stitch to the intercostal tube or suturing, all that matters, right? If something goes wrong, your patient might be paying in life or in complication. Then you should be a good team member and good communicator and a leader of that team eventually, right? That's how you're trained. You should be the leader. Say in absence of your consultant, maybe you are the team leader. You should have ability to lead the team the way you want, right? Then you should develop good rapport with your colleagues. I know there will be differences. I know there will be, clashes between your colleagues, but eventually they are the ones who save you also, right? Right. Maybe you are sick. Maybe one of your patients go bad when you are away for a vacation. Your colleagues' input is very important. So have a good rapport with colleagues without having, having a big rivals in your hospital or the unit. So we should be helping each other all the time. And during operation, you might ask one of your colleagues to come in to help, You may be in a difficult situation. You may be too tired. So ask your colleague to come in. If he's free, he will come and help you. That sort of, genuine mind should be there in your head to call somebody to help. Eventually outcome of the patient is what matters. So you need to save that life, right, to prevent complications. And then develop good communication skills. And with regard to patient as well as healthcare staff, you need to explain the relatives well, pre-operatively, during consent taking, then post-operative, you need to explain them what happened, and condition update. If you can do it, if you have a free time, that's best. But if you can't do it, delegate it to your most suitable junior, right? So whenever possible, you do it because you are the one who knows exact nature of the patient. So do yourself. So then you are not bluffing here and there. Here say mukut kiyanne. You tell the patient the truth and tell the truth to the patient most of the time. Don't hide anything, right? Even if you have done a mistake, just tell them there was a bleeder there. We have tackled it. But now the patient situation, these things have happened before. Be truthful. Otherwise, කොහේ හරි ඉන්න minor staff එක්කනේ ගිහලා වටෙන් ගිහලා කියලා කැතිපොළ උස්සාගෙන තරම් උස්සාගෙන එන ගානට යනකම් ඉන්නේ නැතුව you tell them and then you are guarded. මහත්තයා මේක කිව්වා. මෙහෙම දෙයක් වුණා කියලා. That will safeguard you, right? And you document in the notes also, right? That's very important. Then comes, you should be compassionate and empathetic. Right, empathetic, you should go down to the level of the patient, how patient thinks, their problems, background, traveling, and if it's a cancer patient, how the family could feel this, those things, how to break up bad news, all those basic skills come into play. And then adherence to multidisciplinary approach, right? Even cardiac surgery or thoracic surgery. So you always feel free to talk to others. Well, if you have time, discuss in a proper meeting. Otherwise, talk to different specialties and get the best approach to that particular patient. And just if you are trying to do one thing on one patient, just don't do it for the sake of doing. Cater your management according to your patient's needs and the clinical situation. And always update yourself by reading, by either journals, maybe Googling or webinars, or you teach the juniors, and then attend the conferences, or you do some small audits in your unit and do some research. So those to update yourself, then you tend to, learn more new things. And then stamina and physical endurance also. You have to stand for long hours. Maybe you may not have, 1 hour sleep even. Maybe you have the next day list. You come for a reopening in the night or trauma case in the night. The next day you have a list, but you should have stamina, have some physical energy to endure. It doesn't happen always, but maybe once a month, maybe once in 6 months, but you should be having a stamina to endure that situation. And then emotional resilience, right? Stress of the job, the operation, it may be a very, that operation you may be doing your first time in your life, right? It may be a redo one or highly complicated one, right? You should know how to stress that, how to cope that stress, right? Maybe a staff patient, maybe somebody related to a politician, එහෙමත් වෙනවා දැන් in our stage, we get those patients all, consultant's brother, so and so politician's sister, So you really, it's not just the operation, a lot of, social pressure come into your head, right? So you need to know how to cope that, right? If something goes wrong, අපිට ඒක හරියට වැඩි කරගන්න පුළුවන් වේද, outcome එක මොකක් වේද, we all are human beings. You are a surgeon, but you are a human being. All that factors come into play. So you should have that ability to cope the stress, right? And especially then now this stage you බැනුම් අහනවනේ boss කෙන්, the boss might scold you, might encounter a boss who is very rude boss කෙනෙක් හම්බෙන්න පුළුවන්. That is also part of training, and that helps you to endure the stress, right? Even if you go abroad, some foreign, your trainers are not very, welcoming. උන් අපිට කැමති නෑ සමහරවිට. මුකුත් කියන්නේ නෑ, but you feel something is wrong, there is a gap. So all that is stress, right? Stress එක endure කරන්න, especially when you go about language ප්‍රශ්න තියෙනවා. උන් කියන්නේ උන්ගේ ඉංග්‍රීසි අපිට තේරෙන්නේ නෑ සමහරවිට. They talk same English, but they are, how they pronunciation is different, You may have to ask different, excuse me, sorry, can you repeat it again? A lot of questions you have to ask. If you do wrong instruction, you are doing a wrong thing. You have to make sure that you listen the proper thing, right? All those things are stressed. And then adjusting to a new country, the buying things, spending money, all that comes to stress, even first few months of after going to the foreign job. Right? That is emotional resilience is very important. Right? Right. That's what I have said. You decide on your own, and then we quite welcome cardiothoracic and thoracic training because we have slots in major centers. So you decide after your exam. This is what I need to say. Any questions and doubts, please? It's nearly 12:30. One question asked by the candidate from Candy, one of the registrant asking, what was the question? Okay, regarding clamping. Is it not, I didn't tell about clamping, I said, what is it? Is it not recommended to clamp the tube when transferring the patient? Yeah, because clamping should be done only during position change, say from bed to the wheelchair, bed to the trolley, and then hang the bottle in the lower position and unclamp it. That's what you should do, not to clamp during transport time. No? Because any other questions, please, from previous talk or this one? Hungry? Then it may be. I mean, the things I told you, the qualities, it matters to other fields also. But cardiothoracic surgery, it's more applied, the things I told you. And if you are a good surgeon, you can earn money also. It's not a problem. Wherever you go. I mean, thoracic, cardiac. If you are a weak surgeon, you are not doing well, field you may not earn money, you may not be satisfied with your field.
The question.
Yes, sure, sir.
So,
Yes, sir.
there was an MCQ. After chest trauma, initial blood, after chest tube was inserted, initial blood more than 1,500, and we had to open the chest. There was another response to say that hourly 150 or more. And both responses were there. How should the candidate mark? Which one is true?
Yep, that's why I told you in my lecture also, sir, these come in, but this sort of ambiguous question we will not put in the exam now because different guidelines give different, numbers. So these sort of questions, they strictly say not to put in. Is there any answer to Dhammika? This 1 liter business, hourly 250 thing. So different guidelines say different numbers. I was not there during someone's talk. Can you remember the question?
Question. It then says, clearly says 1,500 ml drainage once, or 150 ml per hour. Guideline says 150 ml per hour.
2 to 3 consecutive hours.
Yeah, about 2 hours. You can't go for the open up. It should be at least 3 hours. So that question is within the guideline.
Response did say that.
Yeah, it is just
Yeah, that's why I told them. So I don't know where someone took the question from. So because after the exam, even our time we did know, so they make questions not directly from PGM question. So we memorize and do know. So that we might miss some crucial, segments.
For do it, we of course did. Machan, for you, first 2 questions. For you, second 2 questions. Before we went even, we knew that we are going to pay. And this was the arrangement. Everybody doing that, but what happens is, everybody writes after the writing, and the person who wants to pass, he never writes anything, but he's being blamed for not writing. So he writes something and give it to you, and you eat your cake next time also. So that has been fun. I think I'm sure everybody's doing it.
And yeah, and good thing about the new system is it's very difficult to fail unless you really deserve to be failed. Because good candidate will be passed because ඉස්සර කාලේ වගේ දැන් අසේ අපි අපේ exam කාලේ cholecystectomy operative surgery ආවොත් we know මේ surgeon ආවොත් මෙයාට මොකද්ද කියන්න ඕනේ, that bias is no more there. Your answers are all there, like in MRCS exam. So same question will be asked, no personal bias. Even if your uttermost rival consultant is in your exam panel, he can't fail you. Even if he fails, if others pass, you will pass, right? So a bias එක නෑ දැන්. So that guarantee is there. If you have done a certain amount of job exam preparation, you will pass.
So if I may add, can you hear me?
Yeah.
Hello. Hello, sir.
Yes, please go ahead. We can
Hello, can you hear me?
Yeah, we can. Please go ahead.
Yes, with regard to that MCQ, I think that was one of the MCQs that I got from one of the senior registrars who has done the exam. And again, like it was asking when to do the this exploration as an urgent or emergency basis, which as you clearly said, which is not an ideal question. I don't know whether the stem is correct and all, but it has clearly asked when to open, and then stems were like 1,000 mils, 1,500 mils. Hello, sir. Can you hear me?
Yeah, someone.
Yeah, 1,500 mils, and then they have given a set of values when to open and all. But what I felt like is like in the ATLS guidance, if they ask a question, it should be probably asked from the ATLS guidance, the reverse guidance. What they say is like this: they have given some cutoff values, but as you said, even I have seen in practical setup, we can't give a set value, and sometimes we might explore before 1,500 or whatever the drainage which they say in the trauma guidelines. And ideally speaking, that sort of section should not be put in the exam. If they are putting idea, then there should be a proper stem saying that according to the ATLS guidance or ATLS protocol, because still they say in the ATLS the exact values when to do this as a protocol.
Thank you, someone. Any other questions?
So I have two questions. When we insert IC tube and we take the post-procedure X-ray, if we find the most peripheral hole is not in place, so do you advise it to reinsert push inside the tube or reinsert the tube?
Yeah, that's a good question. I mean, if the X-ray is done, say within 2-3 hours time, I mean, what practically we do is, you clean with some betadine and you can, what the textbook say is, once it is out, you can't push it in. So if it's days, yes, you can't push it again. If it's within hours, practically what we do, we clean with some betadine and you might put it in. Yeah, in sterile environment, you clean it well. Your tube is fresh, even if that hole is in this one, in the chest wall, but still within the skin, I believe, right? Even if it's out, you may clean and you can put the same tube, but you may not do in our setting we do it. That's honestly උත්තරේ දුන්නේ එහෙමයි. මගේ patient කෙනෙකුට මමත් කරන්න කියන්නේ ඕක තමයි. But textbook thing is, if the hole is out, you are inserting, the outside germs into the chest cavity. All those theoretical questions come. Ideal setting, it should come out and a new tube should go in. And then the next question comes whether to put in the same hole or a different hole, right? So if it's a fresh one within 1 day or even the next day, we might put the tube in the same hole, after cleaning. That's the practical question. Thanks. Exam right? The different practices, those questions will not come to your paper, right? Any other?
So my other doubt is if the tube is blocked with the mucus plug or blood clot.
Mhm.
What do you advise to suck it out, or how can I manage that?
You know, that milk in those days, they practice, there's a, milking device, the tube එක මෙහෙම මේක අපිට පල්ලෙහාට යවන එක. Nowadays, now they don't recommend it. But instead, what you can do is, there is a tubing connect.
Generally, when they, yeah, generally when there is a block, actually that one thing is that you can wash it with saline with using bladder syringe. Otherwise, sometimes what I do is I just pull the tube out and place a new tube, because most of the time I feel it is not very practical. Second time it will obstruct. So it is what I do is I just remove the tube, and with local anesthesia I just put the tube. But your ways, it's correct, because sometimes it works well.
Because it's the nature. The April mucus plug the second one will come and plug it again. No, that's what he said. Tube tube when the tubes are there, nice texture and there is some that fibrin layer forms, and inside also not very smooth, unlike very fresh tube. So as time goes on, the fibrin layer forms inside. Some of the holes are closed. Only maybe one hole, or the distal hole only may be patent. So even if you do this, it might not clear everything. So if it happens again and again, better to go for a second tube. Any other practical questions?
So this is a past question that we have got from.
Yeah.
So a 50-year-old lady awaiting resection of mediastinal mass. She's also having pericardial effusion. Best way to manage pericardial effusion to reduce cardiac risk. The answers were VATS, guided pericardiocentesis with Seldinger method, pericardiectomy, resection of mass with drainage of effusion, and last was pericardial window. How to approach?
Yeah. This question actually will depend on how bad the pericardial effusion is. If it's a very thin, question it's a past question, no, it's not, well characterized. If it's a moderate to severe one, our anesthetist will not happy to give general anesthesia, considering the cardiac risk. In that case, what will happen is the second answer you said, ultrasonic guided Seldinger technique, pericardiocentesis is the best answer, right? If it's a very mild one, if the anesthetist is happy to go ahead, you might go for resection at the same time and do a pericardial window at the same time, right? What we practically do is, if we have a significant or suspicious pericardial effusion, we refer to the cardiologist to put a sheath. Pericardial sheath with the sheath, we aspirate daily. We aspirate that, and then anesthetist is happy with the sheath in, we go for surgery. Any other questions, please? These 2 months you will be spending only a limited time. Just learn the principles. Don't, overload your head with cardiothoracic stuff. Exam more general surgery. Part 2 exam. So
I think so.
before-
Again, as you clearly mentioned, when it comes to the exam, we frequently find that registrars come with these questions. As you clearly said, the stems, like as we also when we did the exams, we tend to find the questions from the previous batches and then try to do it. But as you clearly said, the stems and then answers might not be the exact. So most of the time, what I feel like the trainees, they try to find the exact answer based on those MCQs, which might not be the correct one. So as you clearly said, we have to think about the objectives and the principles and then go for the exam rather than by hearting that MCQ and then thinking that this will come for the exam and all.
Exactly. Exactly, someone. Yes. Thank you. Enough then. Any questions?
Yes, sir. One more question, sir. I have seen now sometimes patients are presented with pleural fistulas, and sometimes they get massive surgical emphysema. And I have seen the puncturing of the skin with a needle. Are we still practicing that?
Yeah, we could do instead of use if it's a very huge one. Yeah, to buy time, but we would rather go for a second tube. We call subcutaneous tube. We put 24 or 28 gauge tube to the subcutaneous space rather. But puncturing, that is even practice even in UK, right? So not only that, some of the surgeons go to the extent of putting a whack on that puncture. So whack design එකට දානවා පොඩි පොඩි cuts දාලා ඉවරලා අපි ඔයව කරේ during our internship. Those surgeons used to do multiple punctures and release the air. So UK, some of the surgeons, they wanted to do whack dressing on one of these holes and put a whack machine also to reduce. So yeah, I mean, you can do the needle thing. What we do is practically what I do is 16 gauge cannula current, cannula ke stiletto going karla, you try and squeeze the air around onto that cannula, right? So that's a good technique. You can do even several punctures. No harm, but better to give some prophylactic antibiotic. Might get some infection. And first place, the question I would have asked is, why surgical emphysema occurs after tube? You tell me, the lady in front with the phone, please. Yeah. Why surgical emphysema after tube? So the patient is say pleural effusion patient. After putting the tube, patient developed surgical emphysema. It was not a pneumothorax.
It has been a insertion technique might be wrong because the not proper seal has been taken place during the insertion.
So what can you do to prevent that? Proper seal in the what you mean is to when you anchor the tube.
Anchoring and also during insertion with the finger.
Yeah, during insertion, mind you, our Robert's forceps. Imagine if this is my finger. When you do this movement, අපේ skin level එකේ movement එක අඩුයි. But I have seen some SHOs and registrars, they put tubes, they put massive, destruction of these two jaws. Whereas most distal, it's a rib cage එක ළඟට යනකොට, it gives us maybe even 3 centimeter stretch. With Robert forceps එක දිගයිනේ මෙතන චුට්ටක් stretch උනාට, the most distal part may be stretching, so it makes a very big hole at the rib level. So leaving your tube is very small, but peritubal, there is a lot of space. So when the patient coughs, then that air which is inside, I mean, even if it's fluid, eventually after putting the tube, there will be some air going in. No? So then when the patient coughs, and you nicely put the stitch around the skin. So there is no way that air could escape. So it will go laterally, causing surgical emphysema. The other thing is that what you said, the sentinel hole is in the chest hole. That is one other cause. And bronchopleural fistula කියලා අපිට එවනේම ගොඩක් ඒවා bronchopleural fistula නෙමෙයි. If it's a broncho or alveolar pleural fistulas, maybe sort of misdiagnosed. Or either your suture hole is not tight enough. When the patient is breathing in, some air is going through the suture hole. What I detect, how I detect it is, I apply some, we remove the, during the ward rounds I do, and remove the dressing and put some betadine around the tube and ask the patient to cough. When the patient cough, you wiggle the tube here and there and ask the patient cough in different directions, and there will be air. You can see there is bubbling. So that means that hole is not tight enough. That means during patient's breathing, the air is sucking through the tube side. So that is another cause. What you said, initial insertion is bad, is another thing. And then vigorous cough after after the putting the tube in might cause, air escape to the subcutaneous space. Yeah. Any other questions, please? And the second part of your question, what can you do other than doing a puncturing? Nowadays, we can use a low pressure suction applied on the bottle. That can be done. And you can give high flow oxygen also. That also helps to absorb air, high flow oxygen. And failing which, if the air is going through you can't open the ICU, and sometimes it get aggravated or scrotal swelling to that level it extends. So if that is the case, better to put a second tube and apply second tube, maybe pleural tube also, and subcutaneous tube, and connect all, and using Y connectors apply same low pressure suction on the bottle. So 12:40, then shall we call it today then? Okay, thank you for coming. Do you have any comments to make, sir? No more questions.
Comments should come from the candidates, the participants.
They're all saturated.
Any comments that you all want to make? Yes, thank you very much. Thank you indeed. The next month's SETS program also will happen roughly around this time. And the posters will be out early. May I advise you, the candidates who are sitting for the exam, obviously they will be studying. Those who want to participate next month, please study around that subject, right? And work on that subject a little bit and then come. Then you will have more problem in your mind and you understand better. So please go through the posters and get ready for the next sets as well. Thank you. Thank you indeed to have come. And thank you for all the participants who are participating from other parts of the country. Thank you.
Thank you very much, sir, from college point of view to giving us opportunity, and my colleagues who one of them is in abroad actually, and others,
it's
besides their busy schedules, agreeing to do this. I really appreciate. Thank you very much.
Thank you indeed. That is very nice because it gives a very great opportunity for every section of every association to take part as well. So the college is also very much benefited in uniting all these associations into the college. So all in all, it's a very good program. Thank you. Thank you indeed. Take care.